Buenos días. Buenos días. Buenas.
Buenos días.
Alfredo, buenos días.
Buenos días. Buenos días.
Hola, doctor Moreno.
Hola, buenas. ¿Qué más? Oye, Mosco, ¿dónde anda? ¿Qué más?
Bien, ¿qué más?
¿Todo bien o no?
Aquí desde la transmisión de mando. Sí.
Muy bien.
Pues traer el tamal. Yo.
¿Qué se va a meter? ¿Quién tiene ahí un...? ¿Qué hubo, Pablo?
¿Cómo vas, Alfredo?
Bien, ¿cómo estás? ¿Estás en
No, pues,
Bogotá? ¿O ya regresaste?
No.
¿Qué pasó?
Retenido aquí.
¿Sí? Muy
¿Cómo
bien.
están?
Estamos por la sala A, ¿no? El doctor Cani creo que está conectado por la sala B. Ya me escribió.
Hola, yo soy el doctor Negrín. Me pidieron que me conectara a la sala A. Me mandaron el link y estoy conectado aquí.
Hola, doctor Negrini, ¿cómo está?
Muy bien, ¿cómo están ustedes?
Se ve un buen clima por allá.
Sí, estamos empezando buena primavera y todo.
La primavera, qué bueno.
Sí, sí, muy bien.
Encantado de estar con usted. ¿Qué más, Mosquito?
Bien, papá.
¿Todo bien? ¿Trabajado? ¿O estos días secuestrado?
Oiga, no, ayer operé, estaba contando un caso buenísimo con Sebas Mejía, paciente
Sí.
de él, pero no tenía famisanar y entonces lo resolvimos ayer.
Ok.
Ayer, cuando el jueves consulta por la mañana, todos los días consulta por la tarde. Y
Ok.
ya están apareciendo ya más pacienticos.
Sí.
Lo que ustedes dejan.
Yo
Oiga,
este
me
mes he
contó
tenido
Pablo que
una
estuvo,
mano de trabajo.
me contó Pablo que estuvo espectacular los de capsular superior, ¿no?
Muy bueno, los dos. Sí, muy bueno, lo de capsular superior, excelente, todo Mijata, Tokish, una muy
¿Estuvo lo
buena.
del doctor Gualo?
Lo oí un rato, es que me ha tocado estar corriendo, hermano, porque tenía una cantidad de trabajo y me llegaron unos pacientes ahí para operar de urgencia. Entonces, pero sí, yo oí casi toda la conferencia del doctor Boaló. Muy bueno, no, excelente. No pude estar en lo de la Prada,
Bueno,
como
muy
que estuvo
interesante
espectacular.
porque bueno, mostrando su técnica de trocoplastia abierta, pero muy chévere porque lo fija con tornillos. No usa suturas,
Todo lo fija.
unos tornillos bioabsorbibles.
Ah, ¿no usa suturas?
No. Pero además, como le dije yo, para ver a los americanos en esa tónica,
Hacer eso.
la trocoplastia chévere. Y
Muy bueno.
que sea él. La verdad
No,
fue.
eso es muy bueno, porque acuérdese, que es un flaquito que estuvo en Medellín en el Congreso de la SCO del último que se hizo antes de volverse ACCART, que yo le mandé un mensaje a usted que estaba hablando de troqueoplastia, el que
Mark
vino
Tompkins.
acá, Tompkins,
Hi,
Mark,
Tim.
Mark Tompkins.
Good morning, Tim.
Hello, I'm here. Hello.
Yes.
Mosco, ¿a qué hora nos pasamos?
Remember, we met you in Madrid.
Yes. How is the conference going? Is it good?
Good. Well, you know, this is a challenge for our association to do this kind of meeting. You know, it's more it's difficult to do it. There are many things to join, you know.
Yeah, no, I'm amazed. I think it's really, really good.
Yes. So we have almost 30 speakers from all around the world. So if you do this in a normal meeting, it's difficult to get that kind of leaders in your country, you know. So, and we think that the pandemic brought this kind of technology to do meeting, and we think it came to stay, you know. So
Yeah.
I think probably all the associations around the world are thinking to do their meeting in a mixed way, as a presential and online. Do you think the same?
Yes, you miss out in certain ways because there's still that talking outside of the meeting that we all value. But I agree, you can get a lot of very good presentations by people not being there.
Yes, yes, that's true. That's true. ¿Quién está de? La doctora Paula no le han dado entrada. How is Coventry with the pandemic?
Well, our numbers are going up of cases, but not like, well, I think in South America you've had it bad, but not the deaths is not going up again yet. We're interested to see how that will affect things. I think there's more treatments now, but the actual numbers of infected people is going up suddenly. And the universities, our kids are at universities and finding themselves being strict and no more drinking after 10 o'clock and these things. But how is it with you now?
Well, we are in the 5th position in terms of people contagious. We are in the 5th position around the world. So we are achieving almost 1 million people infected. But our deaths are low, you know? Right now, we are starting to do the things again, slowly, of course. Our quarantine finished last week. So my question is, what do you think about the vaccine? Because we know that in the Oxford vaccine was an obstacle. What do you think? Do you think vaccine is coming this year?
Yeah, I think we're really hoping for that. That's the only way forwards, isn't it?
Yes.
They've got to do the trials properly and not rush it. They mustn't rush those trials, and we get the evidence we need.
Yes.
We keep hoping for.
Yes.
Hi, Tim. How are you?
I'm very good, thank you. It's great to do this. Really appreciate it.
Yeah, thank
I'm
you.
just sorry
Thank
I'm
you.
not there in person.
Yes.
Paulo is our British representative guy.
It's a pleasure.
It's a pleasure for us, Tim.
Let me introduce to Paula. Paula is our secretary. She's from Bogota. She's a knee surgeon. She's very active and famous.
Buenos días.
Mierda, son las 8.
Muy buenos días a todos. Bienvenidos a nuestro tercer día de Congreso y último día. Espero que este día sea un éxito para para todos nosotros como lo tuvimos en los 2 días anteriores. Vamos a comenzar con un módulo muy importante, lesiones meniscales, con grandes conferencistas que nos van a acompañar: Alejandro Jaramillo, Ramón Cugat, Roberto Negrín y Tim Spalding. Muchísimas gracias por estar conectados con nosotros. Por favor, comenzamos con la charla del doctor Alejandro Jaramillo, lesiones de la raíz meniscal, diagnóstico y tratamiento. Podemos compartir video.
Por la invitación. Vamos a hablar de las lesiones de la raíz meniscal. Importante su definición. Son lesiones radiales ubicadas hasta 1 centímetro en la inserción o avulsiones de la misma, las cuales incrementan la carga del compartimiento. Esto es más importante en el lado medial como en el lado lateral. En la estadística personal las encuentro hasta en el 14% de las lesiones del ligamento cruzado anterior y hasta en el 50% de las lesiones multiligamentarias. Algo supremamente importante es que hay que diferenciarlas. No es lo mismo una lesión del menisco medial a una lesión de la raíz del menisco lateral. Empieza por la etiología. Generalmente las lesiones de la raíz del menisco lateral son traumáticas y las lesiones del menisco lateral se asocian a un proceso degenerativo en mujeres de edad media que tienen una destrucción meniscal. Esta destrucción meniscal en el lado medial se da tanto en lesiones parciales como en completas, mientras que en las lesiones laterales es anecdótico presentar una extrusión. La extrusión en el lado lateral se da generalmente cuando hay una lesión asociada de los meniscos femorales asociadas en la raíz, pero esto es algo raro. En las mediales, hasta el 88% de las raíces van a estar extruidas. Así como que, primera conclusión, es que el riesgo de extrusión es mayor en las lesiones de la raíz del menisco medial que en el lateral por la presencia de estos meniscos femorales. Cuando vamos al lado de la carga, mirar la carga, también se comportan diferentes. Esto es un estudio de análisis finito donde se observa un incremento mucho mayor en las lesiones de la raíz del menisco medial comparada con el menisco lateral. Esto posiblemente se dé porque hay estudios que sugieren que los meniscos femorales transmiten carga en el lado lateral. Estudios sobre cerditos muestran cómo se incrementa la carga hasta un 746% cuando hacemos una sección de la raíz medial y vemos cómo si la suturamos o la reparamos, la carga regresa casi a su normalidad, como lo muestran los trabajos de Harner. Estos estudios en cerditos muestran que si el menisco, aquí está, lo vemos intacto, si cortamos el menisco lateral, su raíz, pues realmente no se incrementa tanto la carga. La carga se incrementa es al cortar tanto el menisco femoral como la raíz, pero vemos como el impacto es muchísimo mayor en el menisco medial que en la raíz del menisco lateral. Vemos como la carga definitivamente es mucho mayor en el lado medial. Y estos trabajos también se han hecho en humanos y los resultados son similares. Aquí vemos con sobre la derecha, la flecha en amarillo, la raíz intacta, cómo se incrementa la carga discretamente al romper solamente la raíz, cómo la carga incrementa más cuando rompemos los dos, y sobre la derecha es cuando hacemos la fijación, como retorna casi a su normalidad. Así que esta es la manera como yo veo que funciona el menisco lateral. Se ancla o en la raíz o en el menisco femoral, pero el anclaje es tan fuerte en cualquiera de las dos que sostiene el menisco para que no se vaya a hacer una extrusión o para que la carga no se incremente. Y así que esta es la segunda conclusión. Las lesiones del menisco medial de la raíz se comportan como una meniscectomía. Las lesiones del menisco lateral de la raíz no se comportan como tal, excepto que tenga asociada una ruptura de los meniscos femorales, donde sí incrementan la carga como si estuviera meniscectomizado. Esto está acorde con los trabajos de Shelburne, que buscó sus pacientes con lesiones de la raíz del menisco lateral. Encontró 33 pacientes con seguimientos mayores a 5 años, donde estos pacientes no tenían osteoartrosis, y tomando radiografías comparativas vio que en el lado lateral no había una diferencia menor a 1 milímetro en estos pacientes. Vemos sobre la izquierda un pivot shift explosivo de un paciente con una raíz del menisco lateral asociada al ligamento cruzado anterior. Arriba sobre su derecha, cómo este pivot shift explosivo disminuye solamente con fijar la raíz, y posteriormente vemos cómo el pivot desaparece al reconstruir el ligamento cruzado y fijar la raíz. En cuanto a la clasificación, esta es la clasificación del doctor Laprade. A mí no me gusta mucho debido a que él está metiendo en el mismo saco el menisco medial y el menisco lateral, que tienen una anatomía diferente, funcionan biomecánicamente diferente, y también el incremento de la carga es distinta. Entonces, las tipo 1 yo las he visto tanto en la raíz del menisco medial como en la lateral. Las tipo 2 creo que son específicas del menisco medial. Las tipos 3 solamente las he visto en el lado lateral. Las tipo 4 las he visto en el lado lateral, pero de manera parcial, nunca completa, y las avulsiones óseas las he visto en ambos compartimentos. La otra cosa es que hay patrones de ruptura que no están descritos en la clasificación del doctor Laprade. Por ejemplo, un asa de Val del menisco lateral, y vemos hay una disrupción del menisco femoral y la raíz del menisco, que lógicamente deben de causar una alteración mecánica importante, o estas avulsiones tampoco sabría yo cómo clasificarlas. Así que la clasificación creo que es difícil de establecer en los patrones definidos por el doctor. La anatomía es distinta, la etiología es diferente, las implicaciones quirúrgicas también. Entonces creo que la clasificación del doctor Laprade debe ser reevaluada, y deberían de venir clasificaciones para el menisco lateral y para la raíz del menisco medial. Esta clasificación de Forkel es importante porque sí le da importancia a los meniscos femorales, siendo la tipo 1 y la tipo 2 lesiones estables porque el menisco femoral no tiene ruptura, y las tipo 3 sí son inestables porque rompe tanto la raíz como el menisco femoral. En cuanto al manejo, yo creo que todas las avulsiones agudas traumáticas son quirúrgicas. Las lesiones óseas asociadas a espina tibial hay que fijarlas. Debemos siempre buscar estas raíces que son frecuentes, y si fijamos primero la espina y después vamos a buscar la raíz, creo que es algo más complejo. El flujograma de manejo que tiene el doctor Laprade creo que es específico, ideal para el lado medial. Aquellos pacientes que estén sintomáticos con el menisco extruido y no sean artrósicos, pues hay que fijarlas. Y para el menisco lateral, para la raíz, creo que es mejor la clasificación de Forkel. Creo que las tipo 1 y las tipo 2 no hay que fijarlas, porque el menisco femoral controla tanto la extrusión como la carga. Y las tipo 3, o aquellos pacientes que tengan un pivot mayor de 2, creo que las debemos de fijar todas. En cuanto a las recomendaciones quirúrgicas, esta es la raíz con un compromiso óseo. La manera como lo hago es que reduzco este fragmento óseo, le paso la guía del ligamento cruzado, hago un túnel y simplemente hago un pull out con un túnel en el fragmento óseo y otro adyacente para reducirla. En el menisco medial es muy importante volver el menisco a su posición, porque si no lo reducimos, pues vamos a fijar un menisco que está extruido y biomecánicamente no va a funcionar. En la raíz lateral, ideal hacer una fijación en doble túnel. En cuanto a las conclusiones, recordar que la etiología es diferente, que las lesiones de la raíz del menisco medial equivalen a menisectomía. Para que se dé esto en el lado lateral, tienen que estar rotos los meniscos femorales y la raíz. Prefiere hacer una doble fijación en la raíz, tanto del menisco medial como del menisco lateral, y siempre estar preparado para encontrarlas, porque sean hasta en el 16% asociadas a lesiones del ligamento cruzado anterior y hasta el 50% de las lesiones multiligamentarias. Muchas gracias.
Muy buenas tardes al doctor Jaramillo y al doctor Rodríguez por esta invitación conjuntamente con la ACCART para estar con todos ustedes en Colombia. Ya digo, muchas gracias y estaremos juntos desde el 24 al 26 de septiembre de este 2020. Y a continuación vamos a empezar hablando de las lesiones meniscales, a ver cómo los factores de crecimiento de las células pueden ayudarnos. Aquí ven el grupo, que es un grupo multidisciplinario que pueden ver veterinarios, médicos y investigadores, etcétera, etcétera. Aquí pueden ver mi disclosure. El menisco. El menisco es un elemento que vemos que es muy importante, que ha sido muy despreciado durante muchos años, pero ya vemos que Fick ya vio qué sucedía cuando realmente el menisco se sacaba y así quedaban las rodillas. O sea que vamos a ver que es mejor repararlos como sea. El menisco es un elemento que vemos muy importante, que pueden ver que hay tratamientos conservadores y tratamientos quirúrgicos entre una rodilla. Y Thomas Landau en 1883 ya empezó suturando. Luego vemos los dos cracks que hemos tenido como Ken de Heaven y Hiroshi Keiichi en las suturas de los meniscos. Y las meniscectomías parciales que corrieron a cargo de estos dos doctores y Jan Smiley en la meniscectomía total y el trasplante de menisco en Alemania con Milachowski. Condiciones para realmente poder hacer una sutura. Lo mejor es que sea un tejido no degenerado. Y realmente, si el tejido no tiene una buena estructura y una buena posibilidad para suturarlo, miraremos de hacer otro tipo de suturas. Y en el mundo de los deportistas de élite tendremos que ver el hacer la sutura o la meniscectomía. Para ello tenemos que hacer un consenso previo y estar de acuerdo. Tipos de menisco hay varios, como ustedes saben. El hacer, como pueden ver aquí, la sutura de fuera adentro. Aquí pueden ver toda All Inside. Esto nos cambió bastante la vida al momento de mirar de salvar los meniscos. Las bases de la regeneración son las células, las moléculas iniciadoras y los scaffolds. Y si queremos regenerar un tejido, tenemos que fijarnos en estos tres elementos. En las células utilizamos las células autólogas no expandidas. Tienen que ser mediante cirugía y realmente pues es un poco más compleja. Utilizaremos las células derivadas de la grasa, la fracción vascular estromal. Tendremos que recordar que estas tienen dos formas, las que tienen una digestión enzimática y las que no la tienen. Las células estromales ante el ligamento cruzado anterior y hemos hecho también a nivel de menisco. Ven que el ligamento cruzado anterior son 20, meniscos son 60. Aquí pueden ver pues la extracción, como se hace en quirófano. Y las proteínas que pueden ser quirúrgicas y no quirúrgicas. Aquí pueden ver los factores de crecimiento. El PRF nuestro es uno de los componentes del PRP y con sus 5 fórmulas que podemos obtener y utilizando fracción líquida y fracción coagulada. Aquí ven unos ejemplos, una lesión radial del menisco externo, es de las típicas, y sobre todo la unión entre cuerpo y cuerno anterior. Miraremos de que nos quede bien suturado, que no nos progrese hacia la periferia. Y pueden ver a la derecha las imágenes. Aquí en esta imagen de vídeo ven que debajo hemos colocado esta malla de fibrina para un momento después suturarlo y finalmente colocarle este factor de crecimiento en forma líquida que se nos va a convertir en malla y hará un efecto de pod ayudando esos factores de crecimiento a la curación del menisco. Y en la imagen de la derecha podemos ver el menisco externo completamente curado. Aquí es una lesión, como ven, perpendicular, luego esta longitudinal y se la sutura con esta pinza y procuraremos incluso aquí, como ven, a través del knot pusher le hacemos esta sutura para así de esta forma el cuerno posterior de este menisco interno que nos pueda trabajar y no tener que quitarlo, y de esta forma seremos conservadores frente al menisco interno. Aquí esta rotura en asa de cubo del menisco externo, y pueden ver en la imagen de la derecha cómo se halla en la imagen de resonancia magnética. Este tipo de sutura es un tipo que realizamos hace unos cuantos años. Aquí en este caso es difícil hacer una sutura del labio superior con inferior, y lo que hacemos es esta sutura que envuelve todo el perímetro del menisco, inyectando, o sea, pinchando desde arriba hacia abajo. Y aquí pueden ver cómo nos queda este efecto, diríamos, como un salchichón. Este es una rotura compleja, es un jugador de fútbol profesional, rotura del cruzado anterior, y además a más pueden ver esta rotura del menisco externo. Como es un jugador de fútbol profesional y muy joven, lo que hemos hecho mirar de mantenerlo a toda costa. Para ello, pues colocamos múltiples suturas para que se nos mantenga el menisco y pueda hacer de protección de este cartílago femorotibial externo, ya que saben ustedes que realmente el quitar un menisco a estos profesionales les puede acortar o hacer apartar del mundo del fútbol. Aquí a la derecha pueden ver ustedes las imágenes de cómo queda después de suturado este menisco externo. Aquí una lesión, está el labio y ha sido resecado este menisco, y lo que pretendemos hacer una sutura anterior, la rotura y posterior, bloquear que se nos abra este labio, y luego pues van a ver que dentro del labio le vamos a abrir, cruentar, y le vamos a colocar una malla de factores de crecimiento. Ven aquí creando esta cruentación, y aquí introduciendo esta malla que la colocamos en medio entre el labio superior y el labio inferior. Queda suturada esta malla que nos irá desprendiendo en su forma de pod de los factores de crecimiento. Luego se le introduce una segunda malla, como ven ustedes aquí, que se la va a colocar en la parte inferior con esta aguja. Miramos que se quede bloqueado por debajo, y luego esto le inyectamos estos factores activados para que realmente nos haga esta malla encima. Y aquí en la derecha pueden ver la forma que nos tiene este tipo de sutura, el cual nos evita la extracción del menisco. Esta es una rodilla de una rotura del ligamento cruzado anterior y de este menisco, como ustedes pueden ver. El ligamento cruzado le hemos colocado una inyección al terminar de fracción estromal. Y han visto la sutura, y ahora ven que al cabo de los 13 meses jugando volvió a romper el ligamento cruzado anterior, volvimos a hacerle otra plastia, y aquí pueden ver cómo nos regeneró este menisco externo. Y aquí pues decirles qué mensaje se puede llevar a casa. Que lo que tenemos que hacer es mantener el menisco, porque mantener la anatomía es mantener la función del menisco, y esto es una protección del cartílago. Miraremos de utilizar las sustancias biológicas, como hemos dicho, tanto los RGF, las células como los scaffolds, para hacer que estos elementos se puedan regenerar. Y la duda que siempre tendremos será en un jugador profesional, que a veces lo que no quieren es perder tiempo y quieren ir rápidos. Pero a veces esta rapidez nos puede crear problemas, sobre todo cuando actuamos sobre un menisco externo, que nos puede crear grandes problemas y que no puedan volver a jugar a su nivel como antes tenían. Por lo tanto, solo me resta decirles que muchísimas gracias por esta invitación a poder hablar de estas terapias biológicas y que tenemos que mirar de reparar la anatomía, recuperar la función, pero siempre pensaremos que la biología nos va a tener una muy amable homeostasis. Muchísimas gracias.
Muy buenas tardes, muchas gracias por esta invitación a nuestros amigos colombianos. Para mí es un orgullo participar en este congreso y hoy día vamos a hablar sobre las lesiones RAM. Mis conflictos de interés. La lesión RAM es bastante antigua, está descrita por Strobel en el año 1980. Es una lesión completa, longitudinal del cuerno posterior del menisco medial que ocurre en la periferia del menisco. ¿Por qué se llama RAM? Porque la anatomía es igual a una rampa. Fíjense cómo la parte posterior del cuerno posterior del menisco medial es exactamente igual a una rampa. Existen distintas clasificaciones, pero esta es una clasificación de la Pratt del año 2016 y que muestra que hay distintos tipos de rampa, desde las que comprometen la unión menisco-capsular a las que comprometen la unión junto con la parte posterior del menisco o dobles compromisos del menisco desde la parte superior o inferior. La verdad es que las clasificaciones no son tan importantes, sino que es importante conocer de que no todas las lesiones de RAM son iguales, sino que están clasificadas porque están en la misma zona de la rampa del menisco, del cuerno posterior del menisco interno. ¿Qué tan frecuentes son? En este trabajo chino de 868 pacientes con lesiones de cruzado anterior encontraron una prevalencia del 18,56% en hombres y un 11,97% en mujeres, bastante frecuente. Pero este trabajo bastante más reciente del grupo de Special Surgery de Nueva York encontraron que en una cohorte de 372 pacientes un 42% de lesiones RAM. Pero de ese 42%, ojo, solamente la mitad, es decir, el 20%, son lesiones RAM inestables. Los otros son lesiones RAM estables que podrían no tener tratamiento quirúrgico o de sutura. ¿Cuáles son los factores de riesgo? Los factores de riesgo, uno importante, es la edad. Las lesiones RAM se ven más frecuentes mientras los pacientes son más jóvenes. En los pacientes mayores de 30, 40 años e incluso mayores de 40 años son menos frecuentes. Otro factor de riesgo es el tiempo desde que tiene la lesión hasta el momento en que se opera el ligamento cruzado anterior y se estabiliza esa rodilla. Esto va aumentando hasta los 24 meses. Por lo tanto, muy importante, los pacientes que tienen una lesión del ligamento cruzado y que tienen una rodilla inestable y demoran su tratamiento, van a tener una mayor frecuencia de lesiones. ¿Son subdiagnosticadas? Por supuesto que son subdiagnosticadas. Es difícil el diagnóstico radiológico desde el punto de vista de las imágenes de resonancia magnética e incluso es difícil el diagnóstico artroscópico porque son lesiones escondidas, están en la parte posterior del menisco medial. Existen muchos falsos negativos en la resonancia magnética que generalmente están asociados al cuerno posterior del menisco medial. Por lo tanto, para tratarlos tenemos que tener un alto índice de sospecha y en este trabajo también del grupo de la Pratt nos muestra cómo el bone bruise, el edema en la parte posterior de la tibia por medial está asociado a casi un 75% de lesiones RAM y es importante por lo tanto tener la sospecha en el momento de ir a operarlo. También para hacer un buen diagnóstico hay que tener una secuencia artroscópica durante la cirugía del ligamento cruzado anterior. Cuando hacemos la artroscopía diagnóstica en el cruzado anterior, hacemos en general los portales por anterior y miramos el compartimento interno y externo. Pero aquí es importante que tengamos una secuencia. Nuestra secuencia en nuestro servicio es nosotros hacemos los portales por anterior, revisamos el estado de los meniscos de esa manera, pero luego entramos a una visión desde el surco, con el artroscopio de 30 grados, miramos hacia la rampa. Si tenemos cualquier sospecha de que haya una lesión porque hay hemorragia, signos de inestabilidad o cualquier otra sospecha de lesión RAM, nosotros tocamos con una aguja desde el portal posteromedial buscando una lesión escondida y en ese caso hacemos un abordaje, un portal posteromedial. Y con eso podemos tener un mucho mejor diagnóstico. ¿Es necesario tratar todas las lesiones RAM? ¿Es necesario suturar todas las lesiones RAM? Este trabajo es un trabajo chino que mostró e hizo dos grupos, un grupo control y un grupo estudio, en el cual un grupo se suturó y el otro grupo solamente se trepanó y se hizo ablación. Se operaron el ligamento cruzado anterior y se siguieron durante 2 años. Y los resultados fueron iguales en las lesiones estables desde hasta 1,5 centímetros, porque no todas las lesiones son estables. Y entonces es muy importante tener un criterio para poder suturar o para poder definir cuándo suturar una lesión RAM. Esta encuesta, hecha por también el grupo de la PRAD, aquí se encuestaron en este trabajo 91 jefes de programas de fellowship en Estados Unidos y lo que se les preguntó es cuándo se decide un tratamiento para hacer una reparación meniscal y lo que contestó el 81% es que lo definían con la estabilidad del menisco. Si ese menisco está inestable con la lesión RAM, se sutura. Si no está inestable, no es necesario suturar. Otra cosa que se les preguntó es cómo hacen el diagnóstico y el 67% lo hace como yo se lo expliqué, haciendo y mirando desde el surco con la visión modificada de Wilkes. Otra pregunta que se les hizo es cómo resuelven esto y el 67% lo resuelven con suturas all inside. Aquí están algunos resultados de la encuesta, los que ya vimos, y también cuánto se demoran en resolver una lesión RAM, y menos de 15 minutos se demora la mayoría. La verdad es que inicialmente esto no es tan simple. Cuando empezamos a hacer este tipo de tratamiento nos fue bastante dificultoso inicialmente, y es así que hay distintos tipos de tratamiento para esto, con distintas técnicas, y aquí están resumidas en este trabajo también de un simposio de lesiones RAM por el grupo francés de Sonerico T, en que muestran distintas formas de abordarlo con sus ventajas y desventajas. Nosotros tenemos una manera, describimos un tratamiento con suturas all inside, en este caso con la sutura del Fast Fix, y lo que hicimos fue lo siguiente. Primero, como les expliqué, hacíamos la visión normal y hacíamos una visión desde el surco, mirando con el artroscopio de 30 grados, y esto es lo que ustedes ven, como se ve la anatomía normal. Y acá en el B vemos el platillo tibial, el menisco medial, y cómo están desinsertos los ligamentos meniscotibiales. Con eso podemos hacer el diagnóstico y si tenemos que hacer un abordaje extra, hacemos un portal posteromedial y en ese portal posteromedial miren cómo se ve la anatomía normal desde el portal posteromedial, la parte posterior del cóndilo medial, el menisco. Y miren cómo se ve la lesión RAM, completamente desinserto y caído los meniscos tibiales. Por lo tanto, es muy difícil de diagnosticar porque esto no se ve desde anterior. Lo que nosotros proponemos como tratamiento, como se caen los meniscos tibiales, nosotros hacemos el abordaje, normalmente hacemos el diagnóstico y por el portal posteromedial tomamos los meniscos tibiales y los elevamos porque están caídos y lo que hacemos es que pasamos por debajo del menisco, pasando un fast fix mirando hacia abajo, un fast fix curvo, y pasamos el primer punto y lo anclamos en los meniscos, en los ligamentos meniscotibiales. Luego de eso retrocedemos y vamos con el fast fix nuevamente, pero lo giramos con la curva mirando hacia arriba y lo pasamos a través del menisco y con eso definitivamente cerramos, hacemos el cierre de la lesión uniendo el menisco a los ligamentos meniscotibiales y dándole la estabilidad a este constructo. Posteriormente, después de que nosotros describimos esto también fue descrito y fue validado de que este tipo de lesiones son este tipo de tratamientos son efectivos y además de ser efectivos son seguros para este tipo de sutura. Como conclusión, nosotros creemos que es importante seguir difundiendo lo que son las lesiones RAM porque son lesiones subdiagnosticadas. Son más frecuentes en hombres, menos de 30 años, en lesiones del ligamento cruzado anterior no operadas hasta 2 años. Hay un subdiagnóstico, no hay que pasarlo en alto porque lo que podría hacer es poner en riesgo la reparación del ligamento cruzado anterior. Los manejos con técnicas de meniscorresis, la verdad es que no tienen muchas diferencias entre sí, lo importante es que quede bien suturado. Como mensaje para la casa, hay que buscar de manera activa esta lesión, mirar en todos los pacientes en cirugía de ligamento cruzado anterior la zona escondida, con visión desde el surco intercondilio y cuando es necesario con visión por abordaje posteromedial en casos de alta sospecha. Si no se hace, habrá un 20% de lesiones no diagnosticadas y un 20% de nuestros pacientes operados de ligamento cruzado anterior no tendrán su problema completamente resuelto. Muchas gracias.
I'm Tim Spalding. Thank you for the invitation to present at this virtual conference. And I'd like to present our experience on meniscal transplants. And I'm based at Coventry in the centre of England. I have no relevant disclosures for this talk. I think we have to start with reminding ourselves of the importance of the meniscus and how it protects the joint surface. And therefore, when this patient's asked the question as to why their meniscus was removed, I think we have to remember about meniscus repair, and I make that point and the message that we should always save the meniscus as best we can and prevent the need for transplantation. The operation involves insertion of a non-irradiated graft, frozen, very much matched by size, AP and medial lateral, then inserted either through a bone bridge technique and in our series through the technique of free graft with sutures through tunnel. If we look first at the effectiveness, then I think we can say that meniscal transplant is clinically very effective, but at the moment we cannot say it is cost effective. And this is a concept of buying time for the patient, improving their symptoms and quality of life. To justify that, our own experience with an update from our paper published in 2019, we've looked at our patients who are minimum 1 year follow-up, and on the right there we can see the mean age is 30 in this group, male 65%, right nearly 60%, and mainly lateral knees, but half of them have had additional surgery either for alignment or joint surface articular cartilage repair or ACL reconstruction. Our overall survival is here with 90% survival at 5 years and 75% at 10 years. We look at the overall clinical scores with IKDC improving and staying consistent over time, and the Tegner group, though sport is not the main aim of the surgery, and we've broken these down into groups. And these groups are reflected here where we've looked at the ideal indications with good joint surfaces against the extended indications where the surfaces are worn down to bare bone in groups D and E, either on one surface or both surfaces. And although it appears significantly different at 1 or 2 years, this is not clinically significant as the MCID is 10. The group E down to bare bone has a higher failure rate at 26%. These are patients with bare bone on both surfaces, and we define failure as removal of the graft or arthroplasty. 10% is the overall failure rate, but higher in those that are worn down to bare bone. Also meniscal further surgery, either trimming away part of the meniscus or repair, then we have an overall 11% failure rate.
Our ideal group, the group A, isolated meniscal transplant with no additional surgery, then we only have a 5% failure rate in that group. And you can see the mean age here is 28 in this group. All the subdomains of the Coos scores have improved, and this improvement is beyond the MCID in all those levels, showing good consistency over time. Our pediatric cohort, those are patients who are 18 or under at the time of surgery. We have 33 who published these results in the Castor Journal in 2019. We have one tear in this group, but these patients are quite badly affected at the beginning and they have a low Tegner activity score, and you can see the Coos score improving. So this is probably our happiest group where we've made the most impact on these patients who have been struggling for a while, having had meniscectomy. Overall, our summary of numbers from Coventry then: 10% fail, 10% tear, which is resulting in repair or resection, and then overall reintervention rate of about 30%. That's removal of suture knots, removal of osteotomy plate, adhesions in the knee, so additional operations. But it is this group here down to bare bone where we need to work harder to improve those results, which is a failure rate at 26% at the moment. For cost effectiveness, we studied this as part of the ESCO European Allograft Initiative, and from that work we published this in the same edition of the Castor Journal last year. The difficulty for the cost effectiveness team through the University of Warwick was that we don't have enough data to know what happens to those patients who do not get meniscal transplant, who have symptoms. That's the 20% or so in trouble with the high pre-op symptoms, and therefore the team could not give a value to that cost effectiveness. It's likely to be cost effective, but we can't say. So we know it's clinically effective, but we cannot give a cost effectiveness figure. Overall survival from the same work, just under 90% at 5 years. We can say 70% at 10 years and 60% at 15 years. And this is good information then to give patients when counseling them about the operation. From the Allograft Initiative work, we put together the clinical reviews, 20 case series. And then if we plot those outcomes, then from that we can draw the summary data for these figures: 90% at 5 years, 70% at 10 years, and around 60% at 15 years. From that, let's draw an idea on the indications. I think we have to say that this is for the symptomatic patient, and it's not in general for the patient without symptoms. It's not prophylactic surgery. Not everyone who loses their meniscus needs a meniscal transplant, and it is a carefully worked out decision. We published this in the Meniscus Reconstruction Forum 2015, the consensus statements, where we outlined that the indication is for post-meniscectomy pain and therefore pain on activity. Knees should be stable at the time of surgery and have good alignment. Age generally less than 50, though this is a relative indication. And the difficult area are those patients who are already down to bare bone, and that's not the main indication for meniscus transplant, therefore. This is the ideal patient: no meniscus, good joint surfaces. We put the meniscus in to provide that cushioning for the joint, and this is our ideal indication. To try and answer that question on whether it is chondroprotective, we did a pilot randomized trial, and that is going to lead on to Meteor 2, the main trial to look for the effect of meniscus transplant. And we could show that at 1 year, the change in Coos score for those patients that underwent meniscal transplant was significantly better than those that just had physiotherapy in that group. What about the future? I think we have to look at the complex knee and work out how best to treat it, and the role of meniscus transplant, the role of revision meniscal transplant surgery and osteochondral allografts to improve outcomes. This is the joint restoration philosophy that we follow. Nothing really works in the leg that's out of alignment, and so osteotomy has to be number 1 for the complex knee, ligament reconstruction number 2, and then meniscus transplant before looking at the joint surface cartilage repair techniques. And I think this is very important as a take-home message. Osteochondral allografts, I think, have a big role here, and maybe this is the way forward to improve our outcomes in those patients who are worn down to bare bone. And Brian Cole has shown that by using osteochondral allografts, he can improve the results in this group to almost similar to those that have a good joint surface. Squaring of the femoral condyles. This has been pointed out, and it's difficult to see how the meniscus transplant can survive in a joint that has got osteophytes and is deformed like this. So perhaps this is a subgroup where we're not going to get such good results, but it is an aspect we need to be looking at. Revision transplant in the future. Yes, I think this is a way we may be going. Patients have had a good result and then re-tear the meniscus. This patient presented 5 years after the first meniscal transplant and is now a year out after revision, having got back to activities. So maybe this will appear more as we replace the meniscus again. We need to fully understand the impact, and we've put a grant application in for a multi-center study, which will hopefully provide more data for the value and the benefit of meniscus transplant. So I think putting that together, I've shown our survival rates that we can say to patients, the effectiveness, the indication for the symptomatic patient, and the future with osteochondral allografts and the ways of treating the complex knee. I finish with the lines from Frank Noyes in his recent article in Arthroscopy, advising in the bottom line here that patients should be advised that meniscal transplant surgery, although beneficial in the short term to buy time, is not curative. Thank you for your attention. I acknowledge all the help along the way in achieving these results. Thank you.
Muchísimas gracias, doctor Jaramillo, doctor Cugat, doctor Negrini, doctor Spalding. Vamos a comenzar entonces nuestra discusión y revisando las preguntas que nos hicieron. Hay una pregunta para el doctor Alejandro Jaramillo. Cuando hay una lesión de la raíz meniscal del menisco lateral, ¿siempre hace doble túnel?
Hola, Paulita. Depende del tipo de lesión meniscal. Yo creo que hay una variedad infinita en las lesiones meniscales. Primero están las lesiones meniscales por abducción ósea. Generalmente ahí solamente hago un túnel transfixiando la parte ósea y haciendo un pull-out. En la raíz que uno encuentra con una desinserción, lo que encuentra la raíz arriba, siempre hago doble túnel. Y el doble túnel tiene una función, un túnel mucho más hacia la línea media en el cual estoy intentando llevar el menisco como si estuviera extruido para meterlo un poco en su posición, y una segunda un poquito más hacia la periferia donde bajo el menisco. En esas estoy haciendo siempre doble túnel, independiente.
Bien. Doctor Negrin, doctor Spalding, ¿ustedes hacen doble túnel en ese tipo de lesiones?
Nosotros hacemos solamente un túnel. Hemos intentado hacerlo con doble túnel también, pero definitivamente nos quedamos con un solo túnel.
Bien. Doctor Spalding.
I do one tunnel as well and then tie the sutures over a button at the lower end. I've tried double tunnel, but it makes it very difficult, the space required. And I think it's important to prepare the bone at the base ready for fixation. I think that's a key part of this operation as well.
Muy bien. Otra pregunta que nos hacen de raíz es si hay lesiones asociadas, ¿cuál es su orden de reparación?
Ok, Paulita. Generalmente son pacientes asociados al ligamento cruzado anterior que pueden tener o no lesión estocondral. Entonces yo generalmente primero hago lo más difícil, que es la raíz. Después hago el gesto que vaya a hacer en la parte condral. Y finalmente hago el ligamento cruzado anterior. Excepto que vaya a poner una malla, porque la malla sería ponerla al final sin líquido. Pero si voy a hacer un injerto osteocondral, primero raíz, después injerto osteocondral y después cruzado, si voy a poner una malla, primero raíz, después ligamento y la malla al final.
Muy bien. Doctor Negrín, igual. Doctor Spalding.
El mismo orden sigo yo, con la salvedad que cuando hablo de hacer el ligamento cruzado solamente hago los túneles y lo último que hago es pasar el ligamento. Es la única diferencia.
Doctor Spalding.
I don't really have anything different to add. I think that puts it nicely into order. Repair the ramp. If we've then drilled the ACL tunnels, that creates space, makes it easier for meniscus and doing the root repair.
Bien. Doctor Spalding, en la fijación de la raíz, ¿cómo la fijan tibia?
We fix the root then over a button on the tibia, 2 sutures through the meniscus root. I think it's important to get a very good bite on the meniscus, at least 5 millimeters from the root, and then either the luggage tag suture or a simple suture to be able to pull that down, feed the 2 sutures through the tibia and then tie them over the button.
¿Con algún grado de flexión?
No, I think the meniscus, the posterior part, will not move much during flexion, so we want to just pull it down tight. We'll cycle the knee, watch the knee as the meniscus sits there before tying it, but I don't think meniscus flexion position is important really.
Muy bien. Una pregunta acerca de las lesiones RAM. En tu charla decías que siempre buscas y a través del surco con el lente de 30 grados ¿logras hacerlo siempre con el lente de 30 grados?
Sí, es importante eso. La verdad es que nosotros nunca usamos el artroscopio de 70 grados. Teniendo la visión de Wilkes en el surco y mirando con los 30 grados hacia la rampa, uno puede tener una visión bastante amplia de esa zona. Si tiene cualquier sospecha, la mejor visión, por supuesto, es a través del posteromedial. Pero nosotros mirando desde el surco, ponemos siempre una aguja y tratamos de tocar la zona de la parte posterior. Repito, si tenemos cualquier sospecha de que hay una lesión, tanto desde el punto de vista de resonancia magnética o tanto desde el punto de vista clínico o durante la cirugía, inmediatamente hacemos el portal posteromedial. Durante un tiempo estuvimos haciendo el portal posteromedial de rutina y lo hacíamos principalmente para que nuestros residentes y fellows aprendieran a hacer y aprendieran a ver el portal posteromedial. Pero con el tiempo hemos empezado a hacerlo de manera más selectiva.
Bien. Doctor Spalding, ¿usa portal posteromedial siempre o con el portal anterior logramos revisarlo?
To see the ramp lesion, then having the knee at about 20 degrees for the medial side seems to allow the best access under the PCL to be able to see, and then fine movements of the knee allows the ability to see the opening of that ramp part. And then use a needle from the posteromedial portal, which then allows the movement and be able to detect it. But I prefer to use a fast fix suture then from the front, be able to hold it in place rather than a posteromedial portal.
Bien. Alejandro Jaramillo.
Paulita, siempre hago portal posteromedial porque me parece que es mucho más fácil poder subir la parte inferior de la rampa, pasarle la sutura meniscal. Yo hago la técnica que el doctor Negrín publicó y creo que en mis manos, que no tengo tanta experiencia, es necesario.
Bien. Si estamos con un paciente de 62 años con una lesión en el cuerno posterior del menisco medial, iniciamos artroscopia y lo que encontramos es una desinserción de la raíz del menisco medial, ¿cómo la manejan?
Paulita, si es una raíz meniscal en un paciente que no es artrósico y si ese menisco está destruido como debería estarlo, la edad no importa. A mí lo que me importa es más el estado de cartílago. Si el cartílago está en buenas condiciones, libero el menisco y hago la raíz, lo llevo a su sitio.
Bien.
Comparto esa opinión. Yo creo que la indicación tiene que ver con el tipo de lesión, la zona, por supuesto, raíz, con el estado del cartílago y con el estado del menisco. Si se cumplen los tres requisitos, obviamente habría que hacerle una reinserción de la raíz meniscal medial, porque si no se comporta como una menisectomía total.
I think that's right, and the point there made about releasing the periphery of the meniscus to allow the meniscus to be drawn back to the root is very important. Sometimes needing to make more of a peripheral around the edge part of the meniscus, and that allows it to draw forwards and then repairing the rim again. I think that's an important point Alexandra made.
Muy bien. Una pregunta para el doctor Spalding. En su trabajo nos decía que el trasplante meniscal no es profiláctico. ¿Qué hacemos frente a una paciente de 20 años con un menisco discoideo que termina en una menisectomía de más del 90%, con tendencia al genupalgo, asintomática, sin dolor? ¿Hacemos observación, seguimiento? ¿Qué exámenes uso? ¿Cuándo hacer el trasplante en esa paciente?
Paulita, yo voy a dar mi opinión mientras que el doctor le contesta. Yo creo que tenemos una herramienta que es la gammagrafía ósea con SPECT, donde podemos predecir el grado de artrosis o la sobrecarga. Esta paciente yo la seguiría con gammagrafía y si veo que tiene una sobrecaptación lateral sería candidato a osteotomía trasplante meniscal. Si está asintomática y no capta la gammagrafía, yo la seguiría en el tiempo. Pero creo que es una paciente que terminará en un trasplante sí o sí.
Doctor Spalding, qué pena, tiene su micrófono en silencio, ¿podemos activarlo? No pudimos escuchar su respuesta.
Oh, I'm sorry, you missed all that. I was saying that we reserve meniscus transplant for the patient who has symptoms. So if the 20-year-old has had a meniscectomy, it may take a few months to get over the operation. Not everyone needs a meniscal transplant. So we'll repeat an MRI scan a year later and maybe a year after that. But if they haven't got symptoms, it's hard to justify an operation that may make the situation worse and can still cause symptoms. So still a careful consideration for the operation.
Muy bien. Doctor Negrín. ¿Qué dices, Mosco?
Lo mismo, la verdad es que el seguimiento lo hacemos habitualmente clínico y radiográfico. Si vemos que hay cualquier tendencia al valgo, tenemos una radiografía previa y vamos controlando. Si hay aumento del valgo, aumento de los síntomas, cualquier cosa de ese tipo, nosotros con eso tomamos la decisión de hacer un trasplante.
Bien. ¿El Mosco quiere hacer un comentario acerca de eso?
Sí, yo entiendo que el trasplante meniscal no es profiláctico porque lo único que mejora el trasplante son los síntomas. En mi experiencia, cuando yo intervine pacientes con gammagrafía positiva, ya encontré daño articular. Entonces, yo siempre me he cuestionado, ¿por qué esperar?
Doctor Spalding.
Yeah, it would be very nice to know that meniscus transplant how effective it is at reducing that joint surface wear. The pilot study, we could see that clinically patients were better, but it was also interesting that patients who had good physiotherapy also could improve their symptoms. The next trial we're doing will be 300 patients and then really evaluate the benefit in a multi-center study of the benefit of meniscus transplant.
Okay.
There's also an element of what sport you can expect afterwards, and a patient will want to go back to football, they will want to go back to high activity level, and if they can do that already, then it's hard to justify the surgery because we're not really expecting people to go back to that high level sport. So once you've done meniscus transplant, we're talking about adjusting their activity level, then they may not be happy with that aspect. So that is another reason to wait till they have some form of symptoms so they can better understand the expectation.
Okay, thank you.
Bien. Doctor Spalding, ¿tiene alguna relevancia la obstrucción meniscal? ¿Cómo evitarla? ¿Qué opina de hacer un anclaje trasóseo en el cuerpo cuando hacemos el trasplante meniscal?
¿Qué relevancia tiene? Ahí me están escuchando, ¿sí? ¿Qué relevancia tiene la obstrucción meniscal? ¿Cómo evitarla? Y si está de acuerdo en hacer anclajes trasóseos en el cuerpo cuando hacemos el trasplante meniscal.
Meniscus extrusion is a big topic amongst the surgeons doing meniscal transplant. Does it really matter? And can we reduce it? It doesn't seem to be the fixation method. Something seems to happen to the meniscus that allows it to push out to the side. Whether it's the shape of the femur that is pushing it out to the side with the flattened condyle, or whether it's the meniscus tissue. We've been looking at the techniques of trying to pull the capsule back into the joint, fixing the mid-lateral or the mid-medial capsule to hold it back, and that seems to make a difference. And that's been studied and looked at. I think there are some very neat techniques for that. So time will tell if that can reduce it and therefore increase results. At the moment, extrusion, big topic, but not clinically different.
Bueno, muchísimas gracias, doctor Spalding.
Doctor Negrín, doctor Jaramillo, doctor Ugarte, nos estuvieron acompañando en este simposio.
Doctor
Spalding, feliz cumpleaños. Supimos que cumplió hace 2 días años. Se me había pasado felicitarlo. Muchísimas gracias.
Thank you very much. Yes, I wish
Hasta
I was
luego a
there with
todos.
you.
Muchas gracias a todos. Gracias por la invitación también. Adiós, Tim.
Roberto, gracias.
Gracias.
Chao, hermanos. Chao, gracias, papá. Gusto verte.
Vale.
Bueno, son las 9 de la mañana. Vamos a comenzar el segundo simposio de ligamento cruzado anterior. Tenemos también un panel de lujo. El doctor Timo Spalding también nos va a acompañar en este simposio. El doctor Gregory Di Felici y el doctor Robert Marks, para ellos dos. Muchas gracias por acompañarnos en nuestro Congreso ACCART. Y vamos a comenzar con la primera conferencia del doctor Di Felici.
Good morning. I'd like to thank the Colombian Arthroscopy Association for inviting me to present my research to you today. My name is Greg DeFelice, and I practice orthopedic sports traumatology in New York City. I do have some disclosures, as can be seen here. However, my most significant disclosure is that I'm biased on this topic. My philosophy with ACL surgery is that there are many ways to skin the cat, and since I have been utilizing ACL primary repair in my practice increasingly over the past 12 years, I'm a passionate believer, and that makes me a bit biased by definition. I'm not here to tell you what is right and wrong. I'm simply here to share my approach and experience with it, and to let you decide for yourselves if this technique can help you with the patients in your practice. Simply put, my philosophy is that we should not have a one-size-fits-all approach for ACL surgery. There are simply too many variables at play, and the reconstruction or nothing approach is too limited in my opinion. This morning I will discuss what I do, how I do it, and why I do it. The procedure is not perfect, and I will freely discuss the limitations. Before I continue, I want to set the stage for my talk by paying deference to some of the giants of this discussion pictured here, including Colonel John Fagan, who recently passed away. It is their work and ideas that we are building on. A synopsis of the historic open ACL repair results is that open non-augmented repair was a 50-50 operation. Although this has to be conditionalized because all tear types were repaired, there was a wide variety of ages and injuries treated, surgery was open, arduous, and lengthy, and the rehab was primeval. Because of these experiences, repair was abandoned in the early 1990s. The theory is that the ACL cannot hold the clot like the MCL does, and that is why it doesn't heal. We do know from prior research that the proximal end of the ligament has better blood supply. In addition, this study looked at biopsies taken from where the ACL had scarred to the PCL and showed very similar histology to the healing MCL, suggesting that perhaps different zones of the ligament have different healing capacities. One of the first papers we published to open the dialogue about revisiting repair was an opinion piece for the surgeon. We opined that maybe we took a historic wrong turn in the research, and that perhaps because we viewed the glass as half empty rather than half full, we threw the proverbial baby out with the bathwater, concluding that the ACL can't heal when in fact 50% of them did heal. Which brings me to this slide that I love to include, because it reminds me that as a resident I was taught that the ACL cannot heal because it has poor blood supply. Well, from the capillary refill that you see here, it's readily apparent that this proximally torn ACL seems to have excellent blood supply. I've learned that this is the perfect tear to perform a repair on. Here, at a 1-year follow-up scope for meniscal tear, you can plainly see that the ACL has healed up nicely. When we probe the femoral attachment, you can see excellent scar tissue formation, and if you look closely, you can see the fiber tape internal brace underneath the scar tissue. Judging from this result, it's certainly possible that the ACL can heal. We must have struck a chord with surgeons worldwide, as interest in the topic seems to be surging across the decade. Briefly, there are 4 main techniques for ACL repair out there, all of which use some sort of augmentation. On the upper left is my suture anchor approach, to which I added the internal brace very early on. On the upper right is the transosseous internal brace approach described by McKay and studied by DeWigi and Wilson. On the lower left is the dynamic interligamentary stabilization, or ligamist technique, which anchors the augment stitch to a rather large spring that is buried in the tibia so that the system has some give. And finally, on the lower right is Martha Murray's bear technique that stitches a blood-soaked collagen sponge between the ends of the ligament to hold the clot. If the number of systematic reviews on the topic is indicative of the interest, then it seems that interest is high. The past 12 months I call the year of the systematic review, since there have been no less than 8 reviews on the topic of ACL repair. I only have time to touch on one. My research group focused in specifically on modern, selective arthroscopic ACL primary repair techniques. We reviewed 13 studies encompassing 1,100 patients and divided the techniques into non-augmented, static augmented, including the internal brace techniques, and dynamic augmented, including the ligamist data. There were no significant differences in patient-reported outcomes between the groups, with all scores greater than 85, and we concluded that outcomes were promising, but that higher levels of evidence were needed going forward. Taking a closer look at the data, we can see that failure rates across all techniques averaged 11%, with no significant differences between techniques. Also note that the dynamic augmented group had by far the most patients. There was a significant difference between techniques when we looked at reoperations and removal of hardwares. Here, the ligamist technique had nearly 40% of their patients have a second operation, the majority to remove the spring from the tibia. My approach, which I call ACL preservation, is focused on my belief that the complete ACL tear on the right has a better chance of healing than the complete ACL tear on the left. And that my internally braced suture anchor technique, when used to repair it, is one of several methods that appear to be safe and reasonably effective in achieving that goal. In essence, what I am suggesting is that we pick the low-hanging fruit off the ACL tree and use a simpler, less morbid approach to achieving knee stability. Let's take a closer look at my technique. Both techniques, with and without the internal brace, have been published with video examples in the Journal of Arthroscopy Techniques. This is a good example of a proximal tear in a 44-year-old martial artist. Using a scorpion suture passer, we begin by passing a number 2 tiger wire up the anteromedial bundle in a Bunnell-type locking fashion. Once we have good control of the AM bundle, this is then repeated for the PL bundle using a number 2 fiber wire. Each of the bundles is then sequentially reattached to the wall using 4.75 biocomposite swivel locks. Here you can see the ACL has been nicely repaired up to the wall and is under excellent tension. When the internal brace technology came around, I quickly adopted it to protect the healing ACL. To accomplish this, a fiber tape is inserted into the AM bundle swivel lock. A nitinol wire is used to retrieve the fiber tape along the ACL through a drill hole in the tibia. With the knee in full extension, this is then tensioned and fixed with another swivel lock, completing the internally braced ACL repair as seen here. Now let's discuss my approach to ACL surgery. I call it ACL preservation. My algorithm is not a simple binary one. Instead, ACL preservation is a published treatment algorithm that is based on tear type and tissue quality. It is based on the findings of this systematic review, where we divided the clinical outcomes of the historic open procedure based on tear type. When we compared a mixed tear type group with a proximal tear type group, we found that the proximal group did better in every recorded outcome measure. Today, I evaluate the remnants and possibility of repair by meticulously scrutinizing the MRI. We've published classification systems in both adults and children, and I tend to focus my repair efforts on types 1 and 2 tears situated in the proximal 25% of the ligament. If I have an excellent remnant, I will perform an internally braced primary repair using my suture anchor technique. If the remnant isn't robust enough to afford a repair, then I will repair what I can and add an augment. And finally, if there is little good tissue left to save, then I will proceed with the reconstruction. Last year, we published this paper looking back at 361 ACLs that I had performed. I was able to repair 158 patients, or 44% of that group. When a multivariate regression analysis was performed, it turned out that age over 35, surgery less than 4 weeks from injury, and BMI less than 26 were all predictive of having a repair. We have multiple publications on my results that I want to share with you. The first was a 2-year follow-up on the first 11 patients showing that 10 of 11 were doing great. The second was the 5-year follow-up on that same group showing that the results were durable, in contrast to the historic experience. Last year we published on the first 56 patients with 2-year follow-up. 29 of them were done without the internal brace and 27 of them with. Overall failure rate was 12%, with 4 in the no internal brace group and 2 in the internal brace group. However, the group sizes were underpowered to detect statistical significance. Outcomes were excellent overall. Currently, we are in final review on a paper detailing the 2-year follow-up on 113 patients with 100% follow-up in the group. This will be the first paper in the literature that was able to break down failure rates by age groups, and the findings are very important. We found that the over 35-year-old group had a 3% failure rate, the 22 to 35-year-old group had a 4% failure rate, whereas the under 21 group had a 37% failure rate. These findings have led me to adjust my indications in my youngest athletes, where I am more likely to place an augmentation graft with the repair nowadays. Failures in this age group are also rather high for reconstructions, and I personally believe that the issues are multifactorial. Nonetheless, I recommend caution and tight indications in this age group. Overall, I have performed over 310 primary repairs, mostly on type 1 and 2 tears. I've been using internal brace with all of my repairs for close to 5 years now. I'm running at about a 12% failure rate, and as I mentioned, it is higher in the under 21-year-old age group. Regarding return to sport with ACL repair, we published recently in the knee on a group of 60 patients with 2-year follow-up. We found that 85% of patients returned to sport, whereas 70% of patients returned to knee strenuous sports. 60% of patients returned to their pre-injury levels, and this likely represents the youngest cohort discussed before that had higher failure rates. These numbers are similar to return to sport after reconstruction. Our most recent publication came out in Arthroscopy. It looked at the difference in awareness of the knee between repair and reconstruction patients. We compared the results of the forgotten joint score between 49 repair patients and 39 recon patients. Normal patients with no history of knee surgery score on average 88. Repair patients scored 85.3 versus 74.5 for the recon patients. And this is consistent with what I see in the office, in that the repair patients feel relatively normal after they recover, whereas the recon patients usually have some complaints. I realize that I am biased because of my research and practice, but I am fully confident that in the not-so-distant future, selective arthroscopic ACL primary repair will be an accepted and reliable procedure in our surgical armamentarium for ACL-injured patients. One of the goals of my research is to fan the flames of the worldwide discussion regarding ACL primary repair, and looking at the literature, it seems that this has been successful. After all, the focus of all of this discussion and research is to make things better for our patients, and there's always room for improvement. I believe that the treatment for ACL-injured patients should be a multifaceted approach. Our toolbox should be chock full of choices on how to restore stability to the knee. In my opinion, patients with type 1 and 2 tears should be looked at as the low-hanging fruit on the ACL injury tree. By using ACL repair with internal brace, we have a low-risk, high-reward surgery to get our patients back in the game. One of the first things that you can do if you are interested in this research is to change your workflow. Study the MRI and then scope the knee before taking the graft. This will allow you to better appreciate the patterns of tears. Practice the technique that you prefer on a cadaver knee. Some even practice stitching the torn ACL prior to proceeding with the reconstruction. Work up to it by starting with older, less demanding population. Understand that it will take time, just like it did when you learned arthroscopic rotator cuff repair, but persist through your learning curve. Most importantly, I want to thank my research team for doing yeoman's work in helping to publish over 30 papers in the ligament repair space in the past 5 years. I would like to thank you again for the kind invitation and also for your time and attention.
Thank you for the invitation to speak today. I'm going to be speaking about primary ACL reconstruction from graft choice to return to play. The topics I'm going to cover are injury prevention, ACL repair, graft selection, my current indications for LET, and return to play. I think it's important to discuss ACL injury prevention. 78% of these injuries are non-contact or preventable. A meta-analysis of ACL injury prevention programs reported that a neuromuscular exercise program yielded a 52 to 85% risk reduction in ACL injuries. This is some of the original work from Norway showing that an ACL prevention program using the rate ratio to compare the risk of injury between the intervention group doing neuromuscular training and a control group showed a reduction of about 50%, about half the amount of ACL injuries with a neuromuscular training program. It's important to know that injury rates are lower when program adherence is higher. So adherence to the program, in other words, actually doing the exercises, is key. I want to talk a little bit about ACL repair as well, since it's a fairly hot topic again more recently. The history of ACL repair is important. There has been found to be a very high rate of failure with 5-year follow-up on the original cohort from John Fagan, published in 1976, of 94% of the cadets reporting instability and many problems with daily activities and sports, of course, as well. At HSS, there was a follow-up of 52 patients who had ACL repair in the 1970s. And this showed 42% of the patients with a KT greater than 3 millimeters, and also lots of unhappy patients with instability. Now, there's a renewed interest in ACL repair, and the question is history repeating itself, or should we even be doing this operation? My colleague Ben Wachuku at HSS did a systematic review of the outcomes of ACL repair recently published in the Arthroscopy journal. It was a very rigorous study, including many, many articles, and at the end they whittled it down to 28 studies. And of these, 61% were case series, level 4 evidence, 18% were retrospective comparative studies, which is level 3 evidence, and only 14% were level 1, that's randomized controlled trials. And to summarize this paper, the failure rates found in the literature were much higher than the published failure rates for ACL reconstruction. So in summary, I just want to give you a few thoughts. I think ACL repair is attractive because it's technically easy and therefore can also be attractive to patients because it's less invasive. But I don't do it for several reasons. Number one, there's no literature to support repair as superior to reconstruction or even as good. Two, there's no such thing as not burning bridges in surgery. That means going to the other side of the bridge and then burning the bridge. You can't go back. A failed repair can be catastrophic for the knee, with irreparable bucket-handled medial meniscal tears being not uncommon, and I have seen that. And lastly, with the more recent interest in repair, there's been some industry involvement, and it's somewhat industry-driven. They want you to use their new implants and new devices to repair ACLs, and that always clouds the science for me. Let's talk about graft selection for ACL reconstruction for a moment. This is our MOON data, looking at over 2,000 primary ACL reconstructions, and the BTB autograft retear rate was about 3.2% in this series, 4.6 for hamstring autograft. So hamstring autograft, about 50% higher, and allograft 6.9%, so over double BTB. This is a study we published almost 10 years ago with Iftach Hitzroni, who was a fellow with us, looking at BTB versus hamstring only in high-quality randomized controlled trials. And we found the patellar tendon group had a 7.2% failure rate and hamstring tendon 15.8%, so about double the failure rate in the hamstrings. And this excellent randomized trial by Nick Matati from Calgary, Alberta, Canada. This was since presented at ACCART and the Canadian Orthopedic Association and then published in JBJS. And he found with BTB, single bundle hamstring and double bundle hamstring, the functional outcomes were the same, but traumatic re-ruptures in hamstrings, both single bundle and double bundle, were about 2.5 times the rate in the BTB group. So I think there's 3 important considerations for graft choice. Allografts tear more than autograft, hamstrings re-tear more than BTBs, and quadriceps autograft, I think we still need more data. It's promising, but I think we need a little more data before wide implementation. So my current practice with respect to graft selection is no more allograft for primary ACL reconstruction or for revision, that matter. The MARS group has found much higher failure rates in allograft revisions. So very, very rare I'm going to do an allograft. BTB autograft is for my young athletes, which are typically males under 30 and females under 25, who are going back to sports that have risk of ACL injury. And pretty much hamstrings for the rest. Patients with open physes, I'll do generally either transphyseal hamstrings or an iliotibial band as popularized by Lyle McKaylee. That's iliotibial band over the top and over the front. And lastly, I will use some quadriceps, but it's typically either for revisions where they've had patellar tendon grafts from both knees, or a revision where they've had a patellar tendon graft already from that knee and they don't want surgery on the contralateral knee. With BTB, recovery of the quad can be slow, particularly in people over 30 and especially people over 40. because, you know, we lose muscle as we get older. It's a little harder to get that quad back. It can be slower in females also, and also people who have small quadriceps to begin with. Sometimes the quadriceps shutdown can be challenging. For lateral extra-articular augmentation, should we be doing LET or ALL? Well, LET has been around a long time, and there is data to support its use, so that's my preference. Here's some studies published with long-term data, lateral tenodesis from the Rizzoli Institute, Zaffanini and Marcacci, and also follow-up of 25 years. And they've also published some randomized data more recently in AJSM, Philippe Neret group from Lyon, France, also with Peter Verdonk from Belgium. So with that long-term data, I'm more comfortable, as opposed to the ALL that was apparently discovered recently as a ligament. There's debate ongoing, of course, about whether an ALL even exists. There's debate about how to define it. The technique is somewhat industry-driven. And lastly, there's minimal clinical data to support it, as opposed to the lateral tenodesis with the iliotibial band. We have decades of data. So my current indications for doing a lateral tenodesis at the time of ACL surgery include revision ACL reconstruction in a patient returning to cutting and pivoting sports, selected, fairly rare, but selected primary cases who tend to be under 20 years of age with 5 degrees of recurvatum or more, and who are returning to cutting and pivoting sports. And lastly, other cases who are at high risk for another reason. So someone who's had 2 failed ACLs and has not had a tenodesis, for example, I'll probably do a tenodesis in that situation. Maybe someone who's failed ACL at ACL or 2 and has a slightly higher slope than average. And here's just a brief illustration of my technique. Here on the left is the hip, the foot is to the right. And here we are dividing the iliotibial band, about a 1 centimeter strip, towards the posterior aspect of the iliotibial band, not all the way to the back so that we leave fibers Kaplan's intact, but towards the back where the tissue is better. And then we will whip stitch the end of that graft and pass it under the fibular collateral ligament. You see, there's the fibular collateral ligament. We're just going under just at the level of the epicondyle, just below the epicondyle. I will place a guide pin just proximal and anterior to the epicondyle, and then I will check isometry. Here I'm not showing you the isometry check to save time, but we did it. We like the isometry. Typically 0 to 30, it's isometric, and it loosens in flexion, so we're not capturing the knee. And then I'll pull it into a socket and fix it with a screw so it's less high profile, very solid fixation, but not high profile. And also you can see we're fixing it in full extension, so we're not going to capture that knee.
Mira.
Lastly, just a few words about return to sport. I'd like to thank Theresa Chaya, who's a physical therapist we work with at HSS, and Polly DeMille, who spent a lot of work pioneering how we test our athletes and help them return to sport safely. Now, the risk of second injury is high. Re-injury risk is the highest in the first year after surgery. That's from Moon data. And it's the highest in young, active patients going back to sport. And there's quite a bit of work to show that the contralateral and ipsilateral ACL re-injury rates are around the same. And if anything, in multiple studies, it may be just a tiny bit higher in the contralateral non-operated knee. And it's similar in males and females. So the ACL re-tear rate is a huge problem, especially in young athletes. So we've developed this return to sport quality of movement assessment, where we assess movement patterns for limitations, asymmetries, and deficits that may demonstrate a risk for future ACL injury. We have a physical therapist and certified strength and conditioning specialist to do the assessment. And in addition to photographs, they use video to provide feedback to the athlete, and if appropriate, their parents and their physical therapist. So we do the first return to sport about 6 months after surgery, after ACL surgery. And we'll also do it after other surgeries or injuries if appropriate. And then we'll do the second return to sport 6 or 8 weeks later with all the same tests and any movement tests that could not be performed safely the first time. So in our first evaluation, I'll do squat, single leg stance, forward step down, single leg squat, jump in place, side to side jump, and single leg bridge. And in the second one, 6 or 8 weeks later, they'll do broad jump, hop to opposite leg, single leg forward hop, and then deceleration from a run, shuffle cut, and 90-degree cut. And here you can see that we're evaluating their movement strategies, how they squat on 2 legs, on a single leg, and then also their movement strategy in the vertical and horizontal planes. And here's what we get, an example of our first evaluation. They'll evaluate lots of things with respect to thigh girth and also range of motion of the hip and the ankle, as well as the knee. And then look at a squat, a single leg stance without a squat even, and looking for many things, including whether they have pain, alignment, control, their strategy, whether it's knee to hip. And then from the side as well, single leg squatting, their alignment, their control, and a single leg bridge, also evaluating for pain, how long they can hold it, and then jumping in place, looking for the similar things, pain, their strategy, whether it's hip dominant, knee dominant, whether it's stiff, symmetry, and alignment. And I think the benefits of these programs are several fold. We give feedback to the patient and the family in real time. The patient receives a personalized rehabilitation program tailored to their deficiencies at this more advanced phase of recovery. But I think maybe most importantly of all, the athletes see their limitations. They see their asymmetries, and it helps us make the case that a return to sports sooner may not be better and may even be unsafe if they're not physically ready and optimized. Thank you. Muchas gracias por todo.
Excellent.
This presentation focuses on the use of allografts in ACL reconstruction. Once again, I bring you greetings from Coventry in England. My disclosures are here. Graft choice in ACL reconstruction really remains very topical in our effort to improve outcome, to minimize morbidity and allow safe and a rapid return to activity. And we have a range of options to be able to choose from, as I've listed here, from the autografts through to the allografts. When we look at graft choice, then that decision very much is based on the cost of the tissue, the availability, the clinical results that we know for our patients, and then the morbidity associated with graft choice. In England, very much our main graft choice in the UK National Ligament Registry is autografts at 99%, but in America there is a much higher use of allografts, with recent papers reporting 22 to 42% use of primary allografts for ACL reconstruction. Allografts are very appealing, with reduced donor site morbidity, reduced surgical time, maybe better cosmetic appearance and a reliable graft size, but there is a concern over the published evidence of the clinical effectiveness against autografts, and that's been unclear, and the point of this presentation is to try and draw out some of that information and see where we're at. This is an example of the data that came out showing how BTB autografts were doing well, but allografts had a much higher failure rate. And this was apparent at the younger patients. These are slides courtesy of Greg Malatis from Kaiser Permanente group, showing how the allografts had a much higher rate of failure, particularly in the younger patient. So this was quite concerning. We know that allografts have different properties. Now we know that diameter will affect the overall mechanical property. We know that older allografts have lower tensile strengths and therefore should be avoided, and a tissue bank should ideally have an age limit for donor tendons around age 40. But gender itself has a minimal effect on the biomechanics of graft properties, so it's not really an issue. Another important point here that graft maturation is much slower for allografts from the normal process. Incorporation is slower, and then the maturation seen on MRI is slower, so this has to be taken into account during rehabilitation to allow for this slowness. Grafts generally are fresh frozen, kept for 3 to 5 years, and there is an issue to discuss on the radiation aspects. Gamma radiation definitely weakens grafts and it will delay healing in a dose-dependent fashion. Less than 2.5 megarads can reduce the effect on the mechanical properties, but that dosage does not really kill HIV virus, so that has to be taken into account. Some reviews from Park and Grassi highlighting the emphasis that radiation has a higher failure for the grafts in systematic reviews. The other aspect for preparation is the use of the chemical methods, for example, BioCleanse. And in this paper, which analyzed over 14,000 patients following ACL reconstruction, showed that any form of radiation with or without chemical processing resulted in a higher failure rate, and then chemical processing itself had a 3 times revision rate against hamstring autografts. This was highlighted in a different paper from the Kaiser Permanente group. And in the middle here, we can see that when they looked at all the factors for ACL revision, then the BioCleanse against not BioCleanse was nearly 2.5 times higher on the failure rate, and irradiation over 1.8 megarads as well had a higher failure rate. This is a review of processed allografts from 13 clinical and 11 biomechanical studies. And across the different preparations here, the clinical failure rates appeared similar. And one of the issues is that graft processing is not clearly described in many papers, the exact methods how grafts are prepared, and also whether low dose or terminal irradiation for the grafts has been used. That is sometimes unclear and variable as well. The infection rate, there was no difference with unprocessed allografts to autografts, and that has been substantially reduced by the use of the vancomycin wrap, reducing infection rates to around 0.1%. And then in the latest review here, the infection rate reduced by tenfold. So this is something we should all be doing. If we look at clinical outcomes, then there have been a few clinical studies, randomized trials since 2000. But I want to go through a bit more with the systematic reviews and show you how those have evolved over time to try and lead to help with our decision making. Some of the early reviews here with the dates in red showed no difference between allografts and autografts, and then in 2013 it started to become clear that allografts were the 3 times failure rate for autografts. And then Yao, a different way of expressing it, BTB autografts had less failure, and then age less than 25 autografts had less failure. And then Mariscalco, autografts and non-irradiated allografts appeared to have the same outcome, and again that was repeated in the next review in 2015. Zheng performed this meta-analysis of randomized controlled trials and a systematic review of overlapping systematic reviews. And the bottom line from that paper was that autografts were better than irradiated grafts, but autografts were not different to non-irradiated grafts. Next paper, also in 2015, looking at 8 meta-analyses with 15,000 patients. The outcome between the 2 types of graft was the same, but younger age was becoming identified as more of a risk factor. Highlighted again in the Wassertein review, 7 studies, patients aged less than 25, with a failure rate 9% for autografts against 25% for allografts. But this review did contain papers that had irradiated grafts, and where non-irradiated grafts were used in 2 studies, then the results were equal between allografts and autografts. Bringing that more up to date, Tim Lording published this paper 2017, looking at 28 studies. So the rate of failure for autografts was less than the non-irradiated and non-chemically treated allografts, and that was less from the irradiated and the chemically treated allografts, which had a higher failure rate. But they emphasized the importance that the failure rate appeared higher in the younger patient with allografts, and two key papers were emerging. A military paper showing a 10 times higher failure rate, even in the non-irradiated and non-chemically processed, and then Kane showing the same thing in patients under age 25, a higher failure rate. Wang, in his review in 2018, a meta-analysis of randomized controlled trials of hamstrings autografts against soft tissue allografts. The autografts had a better subjective IKDC scores, but there was no difference in the failure rate between the graft source. This was a review bringing it more up to date. International Orthopedics 2019, 32 trials. For non-irradiated allografts, most studies seem to be reporting a similar outcome, and therefore non-irradiated allografts could be a good alternative. A summary line from current reviews in 2019 is here. Allografts have been demonstrated to have an increased risk of failure in younger athletes and should be reserved for revision cases and those aged 35 years or older, and I would support that. We looked at cost effectiveness as part of the European Allograft Initiative, and cost is really the main factor. Allografts normally will then add cost. However, there is a paper from Brian Cole's group showing that because there is a quicker time period and so reduced time for harvesting autograft, and there may be more hospital stay if you have an autograft, then the cost can be cheaper by using allografts, a different way of looking at that problem. Has the use of allografts declined? Yes, it has. This is feedback from the Kaiser Permanente group when they recognized that allografts had a higher failure rate. The blue line at the top, we can see a reducing proportion of patients having allografts over time because of that information fed back. Particularly in the high-risk athletes, a 68% reduction in use of allografts, and in the younger patients under age 21, a 78% reduction in the use of allografts. This was similar in the Moon group, where the allograft had been recognized a higher failure in those patients and the younger patients, and use decreased over time. So summary for allografts, the advantage, yes, there's much less donor site morbidity, maybe more predictable graft size against the column on the right. For the disadvantages, increased time to incorporation, the variability in the mechanical strength, the higher failure rate in the young is a key factor, and then the higher cost of these grafts. The American Academy position is here that the strong evidence supports that in patients undergoing ACL reconstruction, the practitioner should use either autograft or an appropriately processed allograft tissue. And because the measured outcomes are similar, although these results may not be generalizable to all allografts for all patients, such as the younger patients or the highly active patients. So caution in the younger, highly active patient. So I think what we're saying here, chemical processing is a higher risk factor for failing, and allografts should therefore be fresh frozen and non-irradiated ideally. The older patients, the outcome is comparable, non-irradiated and non-chemically processed, but rehabilitation time is slower, and therefore that needs to be taken into account. That also applies for the patient under age 25, where failure rates overall in general are higher, and allografts in particular have been shown to have a higher failure rate. Therefore, autografts are preferred. Non-irradiated allografts could be a backup option, but with slower rehabilitation taken into account. And if you are using an allograft, then you need to know the donor age, how the grafts have been prepared, and whether radiation was used. So in our paper that we published last year, the conclusion was that the use of radiation, chemical processing, and faster rehabilitation are important negative factors for the use of an allograft. They should be fresh frozen and non-irradiated, and we need further data on the use of allografts in the younger high-energy sportsmen. So with that, I acknowledge the support of my colleagues in preparing this and all the authors of our paper last year published in the Kester Journal. Thank you.
Muchas gracias a los tres conferencistas, extraordinarias conferencias, y como ustedes lo aprecian, los tres temas son bastante controversiales. Tenemos un poquito menos de 20 minutos para hacer preguntas muy puntuales a cada uno. La primera pregunta que quiero hacerle al doctor Di Felice. Are you listening me? Are you understand? You have the English translation?
I don't have the English translation.
I can hear you. Bob, Kim, are you listening me? No.
Hear me?
Yeah.
Okay. Go ahead.
Okay. So mi primera pregunta es para el doctor Di Felice. En la literatura, aún siendo controversial la reparación primaria de las lesiones proximales, soporta la reparación aguda. En mi experiencia, mi mayor grupo es lesiones crónicas. ¿Usted está de acuerdo en que no importa el tiempo, sino la calidad del tejido para pensar en una reparación primaria de una lesión proximal?
Unfortunately, I'm not getting the translation.
Let me ask the question in English, okay?
Thank you.
Mainly of the paper talking about ACL repair authorized the surgery just in acute cases. But in my experience, I got long experience in chronic cases. So my thought is, no matter the time of the lesion, but it's important the quality of the tissue to do the ACL repair. Are you agree with that, or you just do ACL repair in acute cases?
I completely agree with your statement. We do have a publication where I repaired one that was 11 years out. It was scarred to the PCL, and as you mentioned, there was excellent tissue quality and length such that it could get to the wall. My group is working on the final preparation of a manuscript comparing acute versus chronic, under a month versus over 3 months. And so I have a good experience of successful outcomes when you're after 3 months. I do agree it depends on tissue quality and it depends on length of the tissue, whether you can get it to the wall. I do believe that fewer people have a repairable tear when it's chronic, and you may find more success in the acutes when there's a great healing environment, but it's not absolutely out of the question. So I usually take my patients to the operating room and tell them that I'm going to base what I do for you on what I find in your knee, which most people find fairly reasonable.
Okay. This question is for all of you. We have a huge problem with young people. No matter if you do ACL repair, as Dr. Di Felice showed, but always in the young people that was performing ACL reconstruction. Dr. Sonerico Tate shows in his clinical study in a randomized level 1 that at the extra-articular reconstruction prevent almost 30% of re-injury. So the question is, do you think, for instance, to do ACL repair in young people or doing ACL reconstruction in young people is a good indication in that kind of population?
Who's the question for?
If you got a 25 guy with an ACL repair, do you think that add an extra-articular reconstruction is a good option for that kind of people because that kind of age or rates in repair.
I believe in the fact that adding lateral extra-articular augmentation will help to protect the graft. I think there's good data coming out. Whether you choose to do a tenodesis or whether you choose to do a reconstruction is dealer's choice. And I think that it's important that we have as many options in our toolbox as we can. You know, with the failure rate that I saw, that I've seen in the under 21 crowd, I've shied away from repairing in that crowd. I tend to repair the tissue that I can and add a graft to it. And if I'm concerned, I will add a lateral sided procedure. You know, for certain, not everyone who tears their ACL under age 21 is a high level athlete. And some of them have just unfortunate mishaps. And so repair could have a place, but you have to use it very carefully in that young group to avoid the high failure rates. But as you mentioned, it's not like reconstruction's perfect in that age group. So we've, as a group worldwide, we've got a lot of work to do to sort this out.
So I think it's really fascinating, and Greg, it's great to hear your results again, and you've come to England and spoken about your results. The ACL study group's really focused on moving this to the world of prevention, as Bob mentioned about. That is something we probably can make a big difference on, because we may not be necessarily affecting the outcome of ACLs long term. I'm fascinated to hear your figures there, your latest figures, this 37% failure in the under 21-year-olds. And it's interesting how it has evolved. I don't do it. I've stayed away watching these results. And I think we're getting to that point where maybe we should say it's just not got a role in the young person because of this high failure rate or conversion rate to a full ACL reconstruction. There must be a risk of an issue of what happens when you come for your second surgery in the young person. And I know that Gordon Mackay is not doing it anymore in the young patient, and adding in a form of a lateral reconstruction using a tape on the outside of the knee just to be able to cope with the young person. And our problem was that when this operation was first outlined and described, then it was very much indicated for the younger person, the ideal thing for your 16, 17-year-old to have a little bit of just a repair. But now the picture seems to have very much evolved into it's got no role in that group, and it's much more in the older patient where it might just have a role. So it's interesting how we've got to get that message back out there. I think that it's got this limited role in the young person. We have to do better for sure in ACL reconstruction for that and the prevention. But I really worry that repair is not good for the young person where it's been advocated.
I think, hey, good to see you too, by the way. And a great talk. You know, look, what I will say is I know my research, and I know what I've said, and I know what I've said for all these years. And I've always said that repair is based on tear type and tissue quality. And I've never had enough patients where I could analyze based upon age group and say, oh, look, there's more patients there. And so now I am, and we're about to publish that paper and be freely open that, hey guys, look, this is adjust your modifications, but that's no different than surgery since the dawn of time, right? I mean, we all move forward, learn from things that work or don't work, and then adjust our, that's the scientific method, basically, in a nutshell. And so I agree. But like I said, there's some kids, and this is an interesting thing. Wilson just put out a paper that showed 21 patients under age 16 with no failures at 3 years. And so there's only been 2 papers in young kids, actually only one out of Colorado, Albright's paper that showed a very high failure rate. Mine will be the second, showing a higher failure rate, but a much lower failure rate in the above 21 crowd, less than 5%. And then there's a third paper, Wilson, that shows that the failure rate's not higher. But he was operating on very, very young children where there may be a role to
to try a repair rather than do a physeal or an all epiphyseal reconstruction or a transphyseal or whatnot. I just, again, people, with me, it's not all one way or the other. I think what we need to have is an open mind, and we should learn from each other's experience. It's very easy to poo-poo ACL repair based on evidence from the 1970s, John Fagan's paper, which only had 50% follow-up if you look back at it. It's the most cited paper in ACL repair history, and there's 50% of the patients were interviewed or seen. And so, you know, there's limitations in the old literature, and I think we need to be honest with ourselves that there may be a role, and it may actually not be such a bad thing for people who don't do high-level sports, maybe. And because look, over half the ACL surgeries that are being done in this world are on patients who are over 30.
I'd like to respond to Moscow's question as well, with respect to how to handle the high failure rates in young patients under 20 or 25. I think the first thing we should do is use patellar tendon autograft. That has the lowest failure rate of any ACL operation we know. Adding a lateral tenodesis has been shown by GetGood's multi-center study, including sites mainly in Canada and Europe, that the lateral tenodesis with ITB reduces the failure rate significantly. They did it with hamstrings, so they were doing a stability 2 trial, or they are, with some other sites, Pittsburgh as well, to see if that reduces their failure rate with other grafts as well. But I think adding ITB is a reasonable thing. I do it in patients who are young with hyperextension, going back to high-risk sports. And the last thing is making sure they're ready to go back to sports when they do, because of the risk of contralateral ACL graft failure. And lastly, just wanted to rebut rather my good friend Greg DeFelice and colleague. We've worked together at the Hospital for Special Surgery for over 20 years. We go back, and I think that the repair failure rate issue in young people is similar to allograft. Because young patients fail more with anything, you can study it more easily in the young for statistical reasons, so you identify it in the young first, like allograft. But that failure rate for allograft or repair is higher in older people too. They just don't fail as often. So if you're 40 or over, your failure rate with anything is much lower. And so it's not going to be as readily apparent. It's not going to be as obvious statistically in a study. But if you do a lot of ACL surgery and you see some older patients fail repairs or fail allografts, I always wonder, you know, are we making a mistake in those people? Why not give them the most reproducible option? And lastly, I just wanted to say, you know, at our hospital, I'd say Greg probably does 95% of the ACL repairs. We have, you know, probably over 30 surgeons doing ACL surgery, and Greg does 95, maybe close to 100% of the repairs. As he showed, it's a pretty simple operation. So I think if it was that easy to convince people, we'd all be doing it, because there's some pretty good surgeons at our place who have yet to join Greg, as convincing as he can be.
Okay, the other topic that are hot right now is the sport return. Doing ACL repair or ACL reconstruction. This question is for Dr. DeFelice. Usually the patient that we did ACL repair recover his motion as soon as they can. I mean, it's very quickly. So how long do you advise the patient? How time do you advise the patient to return to do, for instance, soccer, when you do the ACL repair? And if you follow the healing with the MRI or something else?
Sure. You know, I usually with the ACL repair, I agree with you, because the procedure is much less morbid, and people who do it realize, like, wow, these people really do recover quickly. And we can follow it, and the knee's stable. A lot of patients want to go back as early as 3 months because they were running at 6 weeks. And in the beginning, I was very, very worried that everyone, because of their aggressive behavior, was going to tear the repair, but I didn't find that. You know, I've done over 300 repairs now, and the earliest patient to fail was at 3 months, and that patient was drunk, standing on a picnic table, and the picnic table broke. So you know, sometimes things happen, and I wouldn't use that as a, oh my gosh, we have to hold people longer. I think the difference and the decrease in morbidity also comes with, you keep your proprioception, you don't really lose as much quadriceps musculature, you don't have the atrophy, so you can protect your leg much better. And that's what I've learned over the years by doing all these, is that patients know and feel good, and so they tend to go back and do things, and they're reasonably safe at it. So I try and hold them, if they're going back to cutting sports, to at least 6 months at the very least. It's very difficult because they feel so good. For older athletes or people who just want to get back to the gym or do what they can, or go skiing and feel confident and not worry about their knee, a lot of them are back in the gym doing their exercises and just kind of getting back to their life at 3 months. And that's where we can't focus only on the failure rate. You know, yes, I agree, Bob. If you only look at failure rates, patella tendon is the king. But the thing is that people don't want to go through a long, drawn-out recovery. And you yourself admitted that atrophy in the quadriceps can be very, very difficult to recover from in the over 40 age group. So I think we should, you know, we have to look at it in the totality of it. And they're very different cohorts. I'm not saying this works for everybody. I'm trying to be prudent. I'm reporting my results. We've over 35 papers published. And I'm just throwing it out there for people to think about, because the conclusion from the old literature that the ACL can't heal, it's just not true.
I just wanted to, one more comment, because I think it's well said. But I think you're more than throwing it out there. You're actually had a slide saying how people can learn to do it in the lab, practice, like basically encouraging people to do it.
Why wouldn't you?
I think it's still an operation. So if this was a brace or a pill that's reversible, it's one thing, but it's still surgery. So I think if you're doing an operation, do the one that has the best chance of working, is my approach.
Okay.
Let me ask something different about the allograft. Do you have one indication for that young guy to do an ACL reconstruction using allograft? You have a special consideration, or just you don't do it, Bob? I heard you that.
Yeah, I've pretty much stopped doing allograft because, I mean, it would be a very unusual situation. But you know, in the last 5 years, I don't know if I've done one, maybe one patient who really, you know, begged for allograft, and I told him the failure rate was higher and I accepted it. And the reason is I find with a hamstring graft, the morbidity, when you see them at 2 weeks or 6 weeks, is very similar to an allograft. The morbidity of a hamstring harvest is not, I don't think, very significant. So that's why in patients who I'm concerned about their quad, or they're a little older, over 30, over 40, I'll do hamstrings, especially if they're not going back to a cutting and pivoting sport where their failure rate is lower. I think it's a very reasonable option.
Okay, and Tim?
So simple, no, I don't do allografts in the primary, but as you say, there may be a person who's had it on the other side and desperately wants it, and so you want a symmetrical operation. There are some pressures from patients to choose their graft, but no, not as a primary, as a routine. Revisions, yes, quite a lot in revisions, because the morbidity of taking additional tissue, so it gives us a very good option. And the multi-ligament ideal has got a big role there, I think. So that's a different end of a spectrum.
Okay, thank you. We are on time.
I have to agree with Tim.
Yeah.
Sorry, in the multi-ligament, I use allograft routinely, with the exception of maybe a higher level athlete where I may use an autograft in that case, but that's quite rare.
Okay, thank you so much for all of you. Extraordinary topics, hot topics. Thank you for supporting us. We are going to have a break. In 30 minutes, we're going to start they asked for the expert, and Tim and Bob they are going to be with us. Thank you so much to Dr. Gregory. Thank you for your knowledge. Thank you, Tim, and thank you, Bob, for support our meeting. Thank you so much.
Thanks for having us.
Thank you.
Bob?
Sí.
Tu español está mejor. Your Spanish is getting better every day.
Un poquito mejor.
Yes, nice discussion. Nice discussion. Very hot topics. Tim is still with us?
I'm still here.
Oh, thank you. Very nice topics. You know, ACL repair is controversial in all around the world. And high failure in young people is a key problem for everybody. I'm very, I think that we have a huge problem with biologic environment. I think we have more failures than are reported. My thought is in graft doesn't heal very good in the core. No matter what kind of graft you use or technique you use. Because I think so, because many of the patients that we found failures, the second trauma is not a real trauma. So for me, we don't have the solution to get better the healing with the graft. What do you think about it?
I agree, but there are lots of movement towards some biological addition towards this, and I try to look at that evidence and see where it's going, but I think that's the direction of travel much more in North America than in Europe. It's interesting to see how that will work, some biological addition, the PRP type extra to an ACL.
Okay. Yes. Remember, Greg, when we were in Naples, that we talked about the ACL repair failure. When a patient has an ACL repair failure and going to the ACL reconstruction, it's a primary reconstruction. It's not a revision. So for me, this is an advantage.
I think that look, when I go in and look and I'll admit freely my failures, and Bob's revised some of my failures. You know, I've probably revised the most failures since I do the most ACL repairs, and I can say as a whole, knees look better when I go in after a repair than I do when I go in to revise a reconstruction. There's less chondral damage. Sometimes there's meniscal tears because that's what happens. They have an instability episode. But it's rarely that I go in and the knee's a disaster after a repair. Different than
Greg,
reconstructions.
My big problem here is that, you know, our biggest advocate, it's great, you really publish your results and you follow your group, but our biggest advocate in Europe for this no longer does what he says he did a few years ago. He doesn't do it anymore, and that message isn't out there in the young person, and that's given it this bad name. And that's, I'm not, you know, saying that only to this group, we're off air, but that's what's given it such a bad name, that he doesn't publish results and he doesn't even do it anymore. He does a lateral thing on the outside. He doesn't even do it in the young. It's a great shame.
Yeah, Tim, I agree, and we've talked about this before when I was over there, and that. But well, I'll also throw back at you and say, look, double bundle reconstruction came on hard and strong, and I'll say to you that people don't really do that anymore, do they? And most of them didn't publish their disaster results from that. So I think orthopedic surgeons have a long history of burying their bad results and changing the story as things go on. And I'm trying not to do that. I'm trying to just share my results. And that's why my first slide is always, I'm biased, take this with a grain of salt. If you want to learn about it, take it and see what you want to do with it, because ultimately all of this matters in your practice. You know, these giant research studies, you know, the Moon Group does amazing things, but I'm not sure that helps the single individual practitioner who's got to figure out what to do with that patient at that moment if they don't do the procedure that that group is espousing. So I just want to keep the discussion up.
I might just take a break for a few minutes just before we get started. We're starting in a few minutes, are we?
Yes. In 20 minutes.
How are we doing that? How are we
Gregory,
doing the next session?
could you stay with us in 20 minutes? We are going to have a session with some cases, and young guys from our society are going to ask to Tim and Bob and Bob Scan. So are you available? Okay, thank you. So if you wanted, you can take a Colombian coffee before starting in 15 minutes. We are in this room. No one is here right now. Our assistant is in the industry, following the industry. So
are we
yes.
separate? Are we separate groups, or is it case? Are you doing a case for all of us to comment on, or is it separate tables? How are you playing it?
Let me ask, ¿cómo es el caso? ¿Cada quien presenta un caso? The Colombian guys, they're going to present a cases to discuss with you, okay? It's case presentation. It's a case presentation.
Okay, and that's to all of us, okay?
Dr. Spalding, Dr. De Felice, Dr. Marx, thank you very much for being with us. I want to get you to use interpretation, translation, because the presentation is in Spanish, and you have to use the translation, please. In below, right below, you have the icon interpretation.
Yeah.
And can you hear the presentation in English? Yes? Okay.
Yeah. Do you have interpretation American to English?
Yes, American English. Yes. Okay.
Yes.
Okay. If you want take a break, a little break.
No, we want to talk. How is Bob and Gregory? How is New York right now with the COVID? Because Tim told that in England it's increasing the cases.
It's been okay here so far. It's right now not so bad, but we just heard last night that in Florida they're opening all the indoor bars, 100% capacity.
Oh, really?
Yeah, the governor of Florida decided that. So
and in New York, restaurants are open.
They're
bars
open indoors. I think it's next week. No bars, and now it's outdoors, which seems to be very safe because they've been outdoor dining for a long time and our numbers are low. But indoor dining, it's questionable how good an idea that is. Greg, what do you think?
Yeah, I believe that's it. I think they're going to go 25% indoor next week. But the nice thing was the restaurants were panicking because it's getting cold up here, so they didn't think that they were going to be able to keep up the outdoor dining. But they changed the rules for outdoor and said that they can use heaters outside and they can continue the outdoor dining. So hopefully that will save some of our restaurants, because they're really, really struggling with the high rents in New York and then the low patronage because of this whole pandemic.
Did you have colleagues dead? I mean, orthopedic surgeon that passed away because the COVID? Because in Bogota, we had 3 cases.
Really?
One young guy, one from orthopedic surgeon, and 2 older guys, but they were orthopedic surgeons. In USA, in New York, and in Coventry, did you have orthopedic surgeon?
I haven't heard of any in New York. We had at our hospital a lot of, quite a few doctors got it, some of the anesthesiologists, and we had one respiratory therapist die. But I've not heard of an orthopedic. And one of my colleagues, a sports surgeon, was very, very sick, did not get admitted. But I haven't heard of any surgeons dying.
Good thing. So this is a great challenge for our society to do this kind of meeting. We have 3 rooms, at the same time. In the room B is shoulder topics. C room is elbow and hand, and A is knee. So we think that this kind of way that we are learning, I mean by online, came to stay on the time. What do you think? I mean, probably huge society as, for instance, SLARC Society or AOSSM or ESCA have to think to do a mix when they do the meeting. What do you think?
I think it's just the fact that we're talking real time is absolutely amazing.
Amazing, yes.
I think the sky is the limit as far as how we can use this to share knowledge across the world, and it's a really unprecedented time. So I do think this pandemic kind of pushed us to do this, and it's great for all of us. I was on a webinar a couple weeks ago in India, and this is just amazing that we can all share the knowledge base. And Bob and I can virtually fight as to who's right, even though we're only about 100 feet apart. We can sit in opposite rooms so we don't actually fight.
Yeah. Have you did tele office? I mean,
yes.
How was that?
Bob, why don't you take that one?
The
telehealth.
Yeah, that's been, for me personally, I haven't really enjoyed that, because without it's basically like a telephone call, because the physical exam is almost useless, except for range of motion of a total knee. I've found it very, very limited usefulness, but the patients seem to like it more than a telephone call, because I think they feel a little more connected. But it's for the doctor, I think it's not very helpful, and I don't really like it. I've tried to avoid it. Maybe also for someone who lives far for a surgical follow-up, then you can kind of stay in touch with them because they don't want to travel back. So I haven't loved telehealth. It did generate some publications, which I thought were not great. I will say that I think it's like, I agree with everything Greg said. This has pushed us, but part of the meetings is the fun of being there, obviously, and the social side and the discussions. This is a good discussion, but it's hard. It's hard to do this. Usually, don't have this built-in time like we do now. So you know, I think this is going to change things, but I certainly miss, you know,
contact
being there, like everyone.
Yes. Yes, but for instance, Pascal Boileau did his shoulder meeting in July, and they had many assistants from outside of France that probably they can't get if they do the presence meeting. And you know that kind of meeting is a surgery meeting, it's a live meeting. So probably it's a break a paradigm, you know.
Well, another thing is, you know, as you say that, one way to do it, which would save the cost of the travel for the visiting guest, is maybe some people would be at the meeting virtually. So, you know, you'd give your talk virtually, you could answer questions virtually, but you wouldn't have to fly the person, you know, at the expense and the hotel and so forth. So I think a lot of things are going to be different when this whole thing is over, I'm afraid. Some for the better, some unfortunately maybe not.
Yes, you know, as probably we are going to have our SLART meeting. Gregory, do you know what is SLART? Our Latin American Society of Artroscopy?
Sure.
Okay, I'm right now. I am the president, and we are growing in the pandemic time. We grew 4 times. I mean, we had in Chile. We had the last meeting in Chile this year. We had 900 colleagues in our society, and right now we have 5,000.
Wow.
So for me, I took advantage to don't have work, to be involved in our society. So we had right now a huge society. In 2022, we are going to have our meeting in Cartagena. So I hope you be here, you, Greg and Gregory and Bob, because my purpose is to join our continental society. For instance, get a good relationship with ACCART, OSSM, ESCA, ACCART. So I hope that you come to Cartagena and see, this is a beautiful city, you know. Probably it's a well-known city from Colombia. So I expect that you come here. It's in March. It's the first week of March. It's 3 weeks before the AO's meeting in 2022.
Vámonos.
Yes, let's go.
All they had to do was make you president, and 5,000 people joined.
Yes. So probably next year we are going to have a meeting in Panama. It's in July. I'm very afraid with the COVID situation, but I think probably vaccine are going to be available in the first semester of the next year. What do you think? In USA, the vaccine, you know, I mean
That's what it's a topic of a lot of debate now. My research assistant, her mother is working on the vaccine for Pfizer. Her mother is a PhD. And she says it's going very well and be available to some degree, even in early November, maybe. And a lot of other companies are working on it. I think the question is going to be about the data, how safe it is, and how comfortable people are to start getting vaccinated. Number one, and number two, how quickly they can roll it out. Because my research assistant was telling me they need these sub-zero freezers, a special kind of freezer, and that's a rate limiting step because they don't have enough freezers for hopefully soon.
I think for that reason, Academy moves its meeting to August. Do you think?
Yeah, that was done.
Yes.
That was done already. So hopefully by then things will be, especially here, you know, I think, and Greg's probably feeling it too, as it starts to get cooler and people can't go outside, like in the summer here, you can eat outside, you live outside. But in the next month or two, it starts to be unpleasant to be outside for a long time. And
they are going to keep the people inside of the... Yeah, probably. You see in England, Spain, they got a new contagious. That is a problem.
How are they doing down by you in Colombia?
Well, you know, Colombia is in 5th position with contagious around the world. I mean, we are almost achieving 1 million people infected, but our death is less, it's low, you know? We are less than 40%. Right now, our peak is going down. So we have almost 160 people die every day. But you know, the economic is open. You know, we have, for instance, last night we had a special dinner in a restaurant, you know, with isolation, that kind of things that you have to do. But it's open our economy right now.
You know, and our situation has also been, in my opinion, hurt a little bit because it's been politicized. So
yeah, you got a problem right now because you are in election and politics take advantage of that, you know?
In particular in this situation. So it's made things more complicated than necessary, I think, unfortunately. But that's just my opinion.
It just seems a big balance between getting on with life, accepting the disease against all the financial suffering from locking down again. And that's our balance in England, how much you do that. We seem to have less, well, in America, we get the message that lots of people just don't want to shut down and just want to take their chance in life.
Well, it seems like a lot of the world has been able to, you know, do things to reduce the spread and infection, such as masks and distancing and things like that, without completely shutting down.
Yeah.
But there's, you know, there's sort of a bit of a political current here that even that doesn't need to be done. Like masks are unnecessary, and you can have big gatherings, and it's okay. So I think that's where, and that when that is done at a high level, I think it confuses people as to what's necessary, and sort of maybe prevents progress. But I think also there's so much we don't know here and everywhere that it's hard to know what's right. Maybe that's okay.
Yeah.
You really know it with certainty.
We're back to 10 o'clock, all bars shutting at 10 o'clock. Go home, no more gatherings, more than 6 people. So we're not on a lockdown, it's much more restrictive.
I'm sure I can tell you that you're going to have some very engaging television coverage of the coming month in America.
Yeah.
This election is going to be an absolute carnival.
Yes.
Wow.
Yeah, it's going to be a circus.
You know, Colombia opened their flights to North America, to USA, and people that went to America last week, they told me that authorities never asked for nothing, you know? You have a COVID probe? No, they don't ask nothing. For instance, if we going to UK, no one is going to give to Colombian get in because we are in a high infected population. So in the USA, for me, Donald Trump handled this situation for me in a wrong way.
Which aspect of it?
Which aspect? All. You know, I have family in USA and in England also. And my family in USA, I asked, and for instance, when the peak was high, people in Florida went to the beach.
Americans don't like to be told what they can and can't do, that's for sure.
That dates back to the War of Independence. But interestingly, you know, I'm originally from Canada, and they didn't have a War of Independence. They just said to the British, "Can we have our own country?" The British said, "Oh, that'd be fine," and so everything was okay. And up there, people are okay being told what to do. And so I wanted to visit my mother this summer, and there's a very strict thing. They take your phone number, they call you, they even come visit you at your house.
Yes.
And if you're not there, there's some significant penalties. They say fine, prison. And I had a story worked out. I was going to go, and the person who had my letter, who wrote me a letter for the story, said I can't do it. And so I ended up not going. And now that I reflect, it may have been smart, because if I would have got caught, it might have been, I may not be on this webinar right now. It's very strict. So sometimes American, Canada, I feel it's the same thing.
No.
Sometimes, you know, things like this, you see some differences.
Yes.
They don't want us leaking over the border and infecting them.
Exactly.
The ill-behaved Americans.
The Canadian border is open, Bob?
No.
No.
Not yet.
Really tight.
Okay. And how is, Tim, how is the flight in Europe right now?
The what?
Between each Europe country?
Oh, well, you can fly, but then when you come back to England, you have to quarantine for 2 weeks in most places. But we had friends of ours who went to France. You're supposed to quarantine if you come back to England after France. So they went to Italy and then fly back to England, because you don't have to quarantine if you come from Italy. So they're clever. But that's the bad bit. So there's very little travel, because you have to quarantine when you come back.
Well, that's the same thing. If you go to Canada, you can go. You have to have a reason. It has to be essential travel. So you have to have a letter demonstrating essential travel, and you have to quarantine, and they will check on you. So it's complicated.
Yes, we have just 1 minute. ¿Quién va a coordinar esto? Edgar.
Yo, Manuel.
¿Qué hubo, Andrés?
¿Cómo estás?
¿Bien o no?
Bien, hombre. ¿Cómo están todos?
Muy bien.
Hola, buenos días.
Hola, María Cristina.
¿Cómo están? Hola, María Cristina. Hola, Paula. No te veo.
María, podemos iniciar con la interpretación, con la traducción, y ensayamos 1 minuto antes de empezar.
¿Quién va a hablar?
Creo que arranco yo, Edgar.
Andrés, habla, and Bob and Greg and Tim, could you, are you listening in English?
You listen to me in English? Or...
Habla en español un momento.
I will.
Hablar en español.
Todos vamos a hablar en español y
¿Traducción?
sí, hacen la traducción en Zoom.
Ok.
Y presentamos todos los casos en español.
Sí, quédate en el canal de inglés. Perfecto. Gregory, Bob, ¿nos oyen en la traducción? Perfecto.
Okay.
Perfecto. Listo.
¿Me escuchan?
Sí, Manuel. Entonces, 10:30, vamos a dar inicio a nuestra
Who is the
sesión.
clever English interpreter? Is that Maria? Or who?
Yes.
Jennifer. Okay.
Yes.
Put your camera on.
Yes. Perfect.
No, Jennifer. Yes.
Ok. Bueno, vamos a dar
Very clever what
inicio.
you're doing.
Ok.
Perfecto.
Ya. Perfecto. Entonces, vamos a dar inicio a nuestra sesión. Muchísimas gracias. Ya. Muchísimas gracias a los doctores Spalding, Di Felice, Marx por acompañarnos. Tenemos a 3 excelentes cirujanos de rodilla colombianos, jóvenes. Bueno, Andrés ya no es tan joven, pero sí más joven que yo. Pero jóvenes talentosísimos que están en la ciudad de Bogotá y en la ciudad de Cúcuta. Empezamos con Andrés, continuamos con Manuel Bonilla y vamos a dejar de último a María Cristina, aunque las mujeres van primero. En este caso dejamos lo mejor para lo último. Entonces empezamos con Andrés.
¿Me dejas compartir?
Sí, abajo.
Listo.
Comparte.
Listo. Bueno. Dime, acá. Espérate. Un segundito. Bueno, este primer caso...
Aún no la vemos, Andrés, no vemos tu pantalla.
A ver qué pasa. Dame un minutico. ¿No la ven? ¿Tú me estás compartiendo ya?
No, tú compártela de abajo, donde dice compartir pantalla y ya puedes compartirla.
Dame un segundito. Dame un segundito. Aquí arriba. Compartir. Esto. ¿La estás viendo? ¿Están viendo?
Ya la estamos viendo, perfecto.
Ok.
Antes,
Bueno.
pon modo de presentación.
No, dame un segundito.
Listo.
Bueno, es un caso, de pronto algunos lo han visto, en estos recientes días, para una decisión quirúrgica. Una paciente, mujer de 55 años, con una gonalgia bilateral de predominio derecho, con patología muy dada a la articulación patelofemoral, especialmente subir y bajar escaleras, posición sedente prolongada. Utilizo la escala funcional, la escala funcional de Cujala para ambas rodillas, aproximadamente 31. Al examen físico, una rodilla bien alineada, una paciente delgada, una movilidad de 0 a 120 grados, una leve fusión articular derecha y un dolor muy importante al examen de la articulación patelofemoral, la faceta lateral. No encuentro dolor en las interlíneas femorotibial, medial y lateral. Dentro de los estudios que tengo acá, radiografías simples con apoyo, como ustedes ven, esto hace parte del protocolo que tenemos en la clínica para la decisión quirúrgica. Las radiografías laterales de ambas rodillas. Clasificamos en las axiales, utilizamos la clasificación de Iwano. Para mí me dio un Iwano 4 para artrosis patelofemoral. Esos son parte de la escanografía. Y utilizamos el TAC fusión, que combinamos la gammagrafía con el TAC para ver las zonas calientes. Acá nos apoya el grupo de medicina nuclear con estos hallazgos. Estas son las axiales, la parte femorotibial, rótulas negras, el MRI, algunos cortes del MRI con un compromiso, como ustedes ven, de la articulación PF, la lateral, y está un corte AP con algún compromiso leve, como ustedes ven, del cartílago, un poco del compartimento medial. Entonces, bueno, quisiera escucharlas para
Andrés, antes de oír a nuestros expertos, hay dos preguntas por el chat de participantes. ¿Qué índice de masa corporal tiene y qué profesión tiene?
Es una abogada, tiene un índice de masa corporal de 26, es una mujer muy delgada.
Ahora sí, no sé, ¿qué preguntas tienes a nuestros expertos?
Para el grupo, el doctor Spalding, Bob, cualquiera, opciones de tratamiento. Yo tengo hay dos tendencias acá en Colombia. Para mí la primera opción actualmente de unos 6 años para acá es una artroplastia PF. Para otro grupo, por la edad de la paciente, estaría orientado a una cirugía de preservación con una anteriorización, una condroplastia y una facetectomía. Quiero escuchar las opiniones, doctor Spalding.
It's always fascinating to me how these patients can get so much wear and tear, so much complete bone on bone, and yet have managed for so long, as if their arthritis doesn't give them so much pain. And for me, the patellofemoral replacement has become much more acceptable with better results becoming established. So I would tend towards patellofemoral replacement. I happen to use the Zimmer next-gen variety of that. Before that, yes, osteotomy and taking away the lateral facet of the patella, that overhanging beak of the patella was a good option for these, trying to buy time for the knee. But now with good results of patellofemoral replacement, and I think that's a good option here. This is almost a corrugated joint surface. So anything else conservative, I worry that's not going to work and provide the benefit.
¿Usan en sus hospitales de rutina para la decisión quirúrgica solo la MRI o en algunos casos usan, Bob, pregunta para Bob, usan la gammagrafía o solo con la MRI y las radiografías? Bob.
In this case, I think you could see everything from the X-ray quite clear. What I would use what I do use sometimes for total knees, if there's a question about patellar thickness, is a CT scan to determine whether it's too thin to resurface. You know, so that on that merchant view, the patella looked quite thin, and looks like on the lateral it looks not bad. The CT looks acceptable for resurfacing. So I use the CT for that purpose. MRI generally not for this.
Just CT and X-rays, normal X-rays.
See, most of the time in this situation.
Okay. ¿Hay alguna otra pregunta, Edgar, del auditorio?
No encuentro. Yo quisiera preguntar, independiente de la edad, si esta paciente fuera aún más joven con estos hallazgos, y pongamos que es una paciente, ¿me recuerda la edad de esta paciente, Andrés?
5'5". Tengo otro caso como el que tú vas a presentar. Tengo otro caso de 36 años. Muy parecido.
Entonces me iba adelantando al otro caso, pero si esta misma paciente tuviera 35 años, doctor Spalding, ¿su plan sería el mismo?
That's interesting, going back there to that skyline view, seeing how much the patella is overhanging and how thin it is, as Bob says. I'd really want to understand the level of symptoms and the history, how she's got this far. I presume someone like that would have had arthroscopy before, but if not, then it's the flavor of symptoms. And if we can improve the symptoms by mechanical tidying up of the joint surface, then that could help releasing the lateral tissue. I've not been a big fan of the tibial tubercle transfer in this amount of wear, but I know it's reported with good results. But I would generally stick with arthroscopy, physio, braces, and try and manage it conservatively before patellofemoral replacement.
Okay. Edgar, quiero presentar el siguiente caso, que es de una paciente joven, muy joven. Quiero mostrarlo.
Perfecto, sí, adelante.
Ok. Es el caso que pronto Edgar estaba buscando. Otra mujer, dolor en rodilla izquierda, una clasificación de Cujala de 35, un antecedente de una osteotomía de anteriorización izquierda a los 25 años y una artroscopia y una condroplasia sinovectomía hace 5 años. La paciente es una mujer delgada, aproximadamente con un índice de masa corporal de unos 25, 26. Es una administradora de una empresa de hidrocarburos. Con estas imágenes me llegó con un dolor muy importante en su rodilla izquierda, con dos cirugías previas. Como le dije yo, a los 25, tiene 38 años y a los 25 años una osteotomía de anteriorización y hace 5 años una nueva artroscopia. Con estos hallazgos. La MRI. A este paciente la decisión la tomé sin gamografía. ¿Qué opiniones tienen? Propuestas. Una nueva osteotomía más facetectomía, usar algún tipo de membrana, prótesis PF. Quisiera escuchar los conceptos de ustedes. Bob, again.
Yo quisiera preguntarle a Gregory, ¿algo biológico? ¿Pensarías en algo biológico? ¿Ustedes utilizarían algún reemplazo biológico?
Without sounding too lame for avoiding it, I don't have a whole lot to give you because we have a patellofemoral center of excellence here at HSS, and I tend to refer all these patients over to them. You know, I don't. I worry when to the idea of re-osteotomizing that one, you start to deform the proximal tibia so much in a slim patient. I would think that can add problems. So at such a young age, I think that you're going to go towards the biologics to try and get yourself a better joint surface. Although, as mentioned, I just don't have a long list of options in my practice for this. I would try and avoid going to arthroplasty at such a young age.
Bueno, la decisión.
I comment as well?
Sorry, Bob. Go ahead.
Por favor, Bob.
Gracias. So I think in this particular, these two cases, I think the first one is sort of a classic indication for a patellofemoral arthroplasty. The medial and lateral compartments looked almost perfect, and very severe patellofemoral joint, worse with stairs, and sounded like walking was okay. But that's rarely, so that would be someone, as Greg said, I would refer to our patellofemoral surgeons. We have a couple of people who do a lot of patellofemoral arthroplasty, and so I don't. And that's also because it's very rare I see a patient that is such a perfect candidate for a patellofemoral replacement. Most of them have some medial or lateral compartment arthrosis, and therefore I feel a total knee replacement is the right operation. So they have one operation and they're sort of done. You don't have to, a few years later, then do a revision, which also has higher risks, more risk of infection, and it's difficult for the patient to then have a second recovery. You know, I think the second case is a little more challenging because she's only 35, but unfortunately for her, it looks like she's going to require, you know, the same treatment, unfortunately.
Okay. Manejo.
El doctor Alzate, John Byron Alzate, nos pregunta, ¿ustedes qué opinan de un injerto fresco haciendo una artroplastia biológica? ¿Alguien?
Para Bob, porque yo no tengo experiencia en prótesis biológicas, Edgar. No sé, algunos si tienes...
Yeah, I think that like for arthritis of that severity, when it's clearly, you know, bone on bone with osteophyte end stage, I think the results of osteochondral allograft or any type of biological procedure is limited. So just, even though she's young, it's tempting for the reason of her age. I think the right decision was made, and I like the arthroplasty in that severity.
De acuerdo. Ok, pues el resultado fue, la operé hace 2 años. Los resultados...
Este caso es el segundo, ¿de acuerdo?
Segundo. Lo operé hace 2 años con una excelente evolución, realmente.
Todas las respuestas de ellos han sido...
Completa prácticamente su sintomatología. Esa fue la decisión. Tengo otro caso. ¿Quieren verlo, Edgar? ¿O pasamos a Manuel? ¿Qué dices tú?
Discúlpame.
Otro caso, si quieren verlo.
Sí, pasemos el otro caso. Perfecto.
Espérate, Bueno, este es un caso interesante. Ya. Es un paciente de las Antillas holandesas del programa internacional, un muchacho de 30 años que consultó por una deformidad severa en su rodilla izquierda, con limitación para sus actividades normales para su edad, una deformidad que llevaba ya por encima de 10 a 12, 13 años. El antecedente de una fractura de fémur izquierdo, que le hizo un manejo quirúrgico como única patología. Les voy a mostrar este video en el momento que me llegó el paciente y le estaba haciendo el examen físico. Entonces, pues... las fotos con un arco de movilidad completo de su rodilla, realmente sin signos de inestabilidad, Edgar. El diagnóstico que hicimos fue un genu-varus secundario a una lesión fisiaria de su tibia proximal. Esta es la radiografía AP, el CT scan. Esta es la reconstrucción 3D. Ok. La MRI, como ustedes ven, realmente no tenía lesiones en meniscales como tal. Y bueno, dentro de las opciones de tratamiento, se barajaron muchas opciones, osteotomías de cuña cerrada externa, valguisante, cuña abierta medial, cupuliforme, fijador. Quisiera escuchar los conceptos, doctor Greg DeFelici o Bob. Bob?
You want to go for it, Tim?
Sure. Well, you know, I think I'd like to see a hip to ankle x-ray. I'm not sure a long leg view. But I mean, we have a very clear idea of the problem and the deformity without that. And so if the deformity is indeed all in the tibia, that looks to me like it will require a correction of about at least 20 degrees, if not more. I will tackle a deformity of up to 15 degrees with an opening wedge, high tibial osteotomy. But I don't think, I've never tackled a deformity of that size with an opening wedge osteotomy and a plate. So once again, these cases at our makes me feel fortunate to work where I do, because we have deformity correction surgeons, Rob Rosbrook and Austin Fragaman. And I would think that this would require them to use an external fixator to correct that amount of deformity.
Ok, bueno, realmente eso fue un... Tim, ¿alguna de comentarios de
So I
Tim?
would refer it to them to do it.
Ok.
So looking at this, that long leg alignment X-ray would be important, and then understanding the tibial slope change between the lateral and the medial side. If we were scrolling across on the MRI and the CT, and it looks very much like just the medial plateau is dropped down. So I'm worried that by lifting up the whole of by an osteotomy across the whole of the tibia may then cause imbalance on the lateral side. There's maybe one for the hemi elevation with an osteotomy going to the center of the knee. And I think that's where the frame options could be most useful there, rather than, because it would be a big lift up there, as Bob said, so you'd need a graft underneath that if we can to do that. So long leg alignment X-rays to understand the femoral component to this slope assessment. Okay. And then trying to maybe consider lifting up just the medial side, which could well really reconstruct what he had. The rotation aspect as he's walking would be interesting to evaluate as well, if it's just purely a medial drop down. So that's what I would suggest.
It looks like it's not just it's certainly not just a straight varus deformity either. It's like a blouse with that flexion.
Yeah. And
the posteromedial aspect was way down. I do believe that I agree completely with all of you that the external fixator is probably going to be your friend here, probably going towards a skinny wire fixator so you can control those different fragments better. And like I said, Bob and I are spoiled because we have this amazing center where they do incredible deformity work here at HSS, at Rosbrook, and what's the name I'm missing, Bob?
Yeah, Fragaman.
Austin Fragaman and Rob Rosbrook. They do amazing work. And if you're interested, I suggest that you interface with them because they really do teach and share their knowledge well with these crazy cases.
Ok, les voy a mostrar la decisión. Fue dado todas las osteotomías de cuñas, realmente no nos corregían más de 15 grados, como dice Bob. La deformidad cuando la medimos exactamente nos da 31 grados y decidí llevarlo a hacerlo de una forma progresiva con una T de Garches, es el tutor que usamos, con una ostectomía del peroné y una osteotomía, la progresiva. Esto fue ya después del retiro al finalizar el tratamiento después de casi 6 meses con este resultado. Quedó un leve varo residual. Como ustedes ven, eso es unos días antes del retiro ya del fijador externo, pues el paciente bastante satisfecho con el tratamiento. Quedó un leve varo residual que creo que, creo que es manejable. Esos eran los casos, Edgar.
The varus is almost matching the other side, so he's symmetrical now.
Sí.
Nice job.
Excellent. Gracias. Gracias.
Results.
Gracias.
Standing.
Ok, eso Edgar. Ahora creo que sí.
Bueno, muy bien, muchísimas gracias, Andrés. Vamos a continuar entonces con Manuel. Manuel, por favor, preséntanos tus casos.
Ok, muy buenos días. 2 segundos. ¿Ya están viendo mi pantalla?
Sí, perfecto, Manuel.
Ok, bueno, el primer caso es una paciente de 39 años, economista que practica actividad deportiva 3 veces a la semana. Consultó por un dolor lateral en la rodilla izquierda después de un trauma rotacional durante actividad deportiva, que no mejoró con el reposo, ni los AINES, ni la terapia física. A su examen físico presentaba signos meniscales laterales positivos, los ligamentos estaban estables y una alineación en valgo bilateral. La resonancia inicial de la rodilla izquierda mostraba una ruptura compleja del cuerpo y los cuernos del menisco lateral, que era un menisco discoide, los ligamentos estables, íntegros, y una superficie articular con lesiones condrales de espesor parcial en el cóndilo femoral lateral. Bueno, comienzan las preguntas. Con los diagnósticos, ¿qué exámenes adicionales pedirían para este tipo de paciente? ¿Una radiografía comparativa de rodillas con apoyo? ¿Una gamografía ósea? ¿O una ortorradiografía? ¿O si pensarían en pedir algún examen adicional?
¿Quién de nuestros expertos quiere iniciar?
It's Tim here. I'm not sure I fully got the whole history, but I would agree X-rays with the weight-bearing view and particularly the flexed view, the PA 30-degree flexed view, and long leg alignment X-rays in addition to MRI scan to fully evaluate the meniscus.
Okay. ¿Alguno más?
I agree that I think it's critically important to get long leg alignment films. I think far too often that is that's left out of the workup, and it's an important thing that we all can learn from and in treating these patients.
Ok, perfecto. Y con estos diagnósticos, ¿qué tipo de tratamiento le propondrían a ella? ¿Una artroscopia con una meniscoplastia lateral y una condroplastia? ¿B, un trasplante meniscal lateral y una condroplastia? ¿O C, una osteotomía femoral varizante? ¿O todas ellas?
I'm not sure I've really got the diagnosis here. May just need to go back a bit. I missed something here.
Ok, el diagnóstico era una ruptura compleja del menisco lateral, ligamentos estables, lesiones osteocondrales del compartimento lateral y una alineación en valgo bilateral simétrica.
Pero Manuel, ¿por qué no nos muestras la resonancia y la radiografía que tienes y así podemos ya corroborar los hallazgos? Ya después de los diagnósticos, muéstranos las imágenes y ellos podrían como ya con eso tomar una mejor decisión de tratamiento.
Ok, les voy a mostrar el tratamiento que se decidió la primera cirugía. Se le hizo una artroscopia en la rodilla izquierda. Se encontró una ruptura compleja del menisco lateral. Tiene una condromalacia grado 3 del platillo y del cóndilo femoral lateral en la zona de apoyo. Los compartimentos medial y patelofemorales eran sanos, normales, y tenía y los ligamentos eran estables. Se le hizo una remodelación del menisco lateral y se hizo una condroplastia. Con estos hallazgos, ¿qué le recomendarían a su paciente como siguiente paso? A, le recomiendo solamente terapia física y esperar a que tenga más síntomas para un tratamiento quirúrgico adicional. La programo para un trasplante meniscal, teniendo en cuenta que es una paciente valga simétrica para un trasplante meniscal lateral. O la programo para una osteotomía del compartimento, una osteotomía femoral varizante para proteger el compartimento lateral.
I think it's for a little difficult to say, without images. If the alignment is normal and the cartilage is intact without osteophytes, and the symptoms are significant, then failed non-operative treatment, that may be a case where lateral meniscal transplant can be considered. Conversely, if there's more lateral compartment wear along with valgus deformity and significant symptoms that have failed non-operative treatment, then an osteotomy may be appropriate. And usually the approach will be, in my approach, is a lateral distal femoral opening wedge, although of course, it depends on imaging. And then, of course, if the symptoms are not very severe, obviously, we may consider non-operative management depending on the case.
Ok. Estas son las imágenes. Se llevó a una segunda cirugía. Se decidió hacerle una osteotomía femoral varizante lateral. Se encontró en la artroscopia nuevamente una ausencia del menisco lateral, una condromalacia nuevamente del grado 3 del compartimento lateral, y los compartimentos medial y patelofemoral estaban sanos con unos ligamentos estables. Esta es la resonancia posterior a la osteotomía, pues en que vemos la ausencia completa del menisco lateral y ya vemos una alineación en el centro. Volvemos nuevamente a la pregunta. La paciente nos refirió que leyó en internet que la ausencia del menisco lateral producía artrosis y ella continuaba con dolor en el compartimento lateral y con derrame articular. En sus opciones terapéuticas le recomendarían hacer terapia física y esperar a que tenga más síntomas para hacer un tratamiento quirúrgico adicional. La programa para un trasplante meniscal lateral, la envían con el psiquiatra o solamente hace el retiro material de sus síntesis y utiliza algún tipo de infiltración intraarticular.
Just to clarify, this is the same patient?
It's the same patient, yeah. Es la misma paciente.
Yeah. You know, I think it's critically important to, before you undertake a meniscal transplant, to be sure that your patient is appropriately motivated and is going to tolerate that procedure well. There's not very many places in the world that do a lot of meniscal transplants, and I would also I think that we should all try and get these rare procedures to centers that can actually gain an experience at it, you know, not unlike ours or Tim's, or I'm not sure down in Colombia. But if it's a one-off or a procedure that the surgeon's doing less than 5 times a year, I would transfer it to the city, to one of the big centers. And you know, it all comes down to how well is the compartment maintained, and if you're going to and your alignment, if you're going to undertake that meniscal transplant. And because it's a big surgery and a big recovery, if the patient's not having many symptoms, I think very few of us tend to undertake that procedure prophylactically. Even though you know it's going to happen, that she's going to eventually develop symptoms, very few of us will proceed before they're having symptoms.
Ok, en este momento ella estaba con dolor lateral y efusión, derrame articular. Tenía síntomas.
Can you say that again? I'm sorry.
Ok, a este momento la paciente tenía síntomas de dolor lateral en la rodilla y edema, derrame articular de la rodilla.
And how long is it since the osteotomy?
6 meses.
So I think that's still a little early to judge the results of the surgery from an osteotomy. And, you know, I would manage her with therapy, anti-inflammatories. And also, you know, I didn't get a great view of the plate, but the plate, I don't think it was the Tomofix, which is the one I use. But the Tomofix plate anyway, can't really see. It doesn't look like it.
Arthrex plate, the Poodoo plate.
Yeah.
Contour look.
That's maybe a little lower profile, but nevertheless, under the iliotibial band, those can be very irritating to the iliotibial band, and especially in a female patient who's not very large, the plates are, you know, especially irritating. So I would like to get that plate out. I usually wait a year. I may cheat a little bit at 10 or 11 months and remove the plate, and that may relieve some of the symptoms as well.
Okay.
Yeah, I think you've highlighted that approach, that we're looking at the patient to understand their true level of symptoms and the flavor of those symptoms, if it's a mechanical catching or an overload pain, and then addressing the issues of alignment first, correcting that. And it sounds like the discussion was, we'll correct the alignment, and then if it's still trouble, maybe move to stage 2. But if it's a mechanical meniscal symptoms, then arthroscopy, removal of the plate, would probably be a good option. But if it's just that overload pain still, because she's quite significantly, well, there's a definite varus there with the weight-bearing line about 40%. So understanding that pain, but I agree she's heading for meniscus transplant, having done that osteotomy.
Ok. ¿Alguno hubiera hecho de primera instancia la artroscopia y de una vez la osteotomía?
I think if the pain is now pure overload walking pain in the lateral compartment, and it was only 6 months ago that an arthroscopy was done at the same time as the osteotomy, and we know the state of the joint surface, that it's not bone on bone, then meniscus transplant now becomes indicated with lateral pain. And if it's not the plate, then great, we're lined up for it.
Ok. La paciente fue llevada a una tercera cirugía en la cual se le hizo una nueva artroscopia. Se encontró una ausencia del menisco lateral, una condromalacia grado 2 del platillo tibial y el cóndilo femoral lateral en zona de apoyo, los compartimientos medial y patelofemoral sanos y los ligamentos estables, y se le hizo un trasplante meniscal lateral con una técnica de dovetail. La paciente mejoró su sintomatología en gran medida, pero presentó un nuevo evento traumático ahora de la rodilla derecha. Haciendo ejercicio, tiene un trauma rotacional de la rodilla derecha, la rodilla contralateral, y refería que también le dolía sobre la placa que tenía en la rodilla izquierda. El examen físico de esa rodilla derecha también presentaba signos meniscales laterales positivos, ligamentos estables, la alineación en valgo de ese miembro inferior derecho, y la resonancia mostraba lo mismo que ha mostrado la resonancia de la rodilla izquierda. Una ruptura compleja del menisco lateral, por su menisco discoide, meniscos y ligamentos estables, y las lesiones osteocondrales en el cóndilo femoral lateral. ¿Qué le harían ahora a la rodilla derecha?
¿No están esas imágenes de esa rodilla, la resonancia?
Esta es la resonancia. Esta es la resonancia post-artroscopia con menisectomía por la lesión compleja.
O sea, a esa paciente le hiciste ya la artroscopia y se hizo una menisectomía. Y así está en este momento. ¿De acuerdo?
Está en ese momento.
Ya. Hay una radiografía panorámica para saber cómo está. Ok. Perfecto. Ya con esto, ya esta rodilla ya podemos empezar a hacer una mejor discusión. O sea, si vemos una rodilla valga, con una ausencia completa del menisco externo, y con ya cambios artrósicos incipientes, me pareció. Ahora sí con esto, doctor Di Felice, ¿usted qué le propondría a esta paciente?
I think Looks like he had to step away for a minute.
Dr. Spalding.
So the situation now, she's got a corrected left knee and had the plate removed. So she's been through 2 or 3 surgeries and hopefully finally ended up with a happy knee situation. Frustrated that her right knee is causing trouble. And we've got definite valgus. The joint surfaces are still reasonably good. And no good functioning meniscus on that lateral side. So she has to really make a decision. Was it worth it on the left? And then pointing towards doing simultaneous osteotomy and meniscal transplant if she really wanted to go through with it. The minimum really would be osteotomy because she's in trouble on that lateral side and she knows where she was going downhill on the left. So she may help make her own decision by doing by saying, yeah, combined procedure, meniscus and osteotomy because it worked on the left. Or she may just run away and not have anything.
Toma en cuenta la realización o no de deporte de contacto. Dr. Spalding.
I think she's in trouble, really. This is difficult to get her back to her aims with that. If we've done surgery on the one side, and she's 39, probably 40 now or more.
Okay.
But if she's happy with the left side and it worked, then great. She'll buy into going all the rehab on the right side and do that.
Realmente no. Okay.
I was going to say, I think the comments about contact sports is something that, and counseling patients to perhaps give up contact sports is something that we shy away from all too frequently. I think a very focused conversation should be had with this patient that the goal in life with these types of surgeries has nothing to do with contact sports and everything to do with how well you're going to do going forward in life. So I don't know how much contact sports comes into play if I was counseling the patient.
Bueno, esta paciente en este momento está contenta con sus rodillas y no se le ha hecho osteotomía ni trasplante de la rodilla derecha y está en observación. Gracias por sus comentarios. ¿Algún comentario más o seguimos con el siguiente caso?
A mí me gustaría, el doctor Spalding nos dijo que pues estaba de acuerdo con la osteotomía. ¿Cuándo decidir entonces hacer las dos cirugías al tiempo, la osteotomía y el trasplante meniscal? ¿O debemos siempre hacer primero la osteotomía y luego el trasplante? ¿O alguno de ustedes haría de entrada las dos cirugías y resolver todo el problema?
I tend to do both at the same time, but they are separate operations. My preference is a medial closing wedge osteotomy, lifting up vastus medialis, doing the osteotomy, and that becomes, that's a fixed operation done because the meniscus transplant then is a lateral. When doing lateral opening wedge, I just found too much irritation from the plate on the IT band. So I've moved away from that and gone medial, where you then get closing wedge bone on bone position, which then helps with the healing. So I would do the combined that way.
You know, I think also this is an interesting case because the patient has had sort of the same thing on the other side and had a good result. That always gives me confidence because assuming the patient is reliable, we can ask them and say, listen, you've been through this, you want to do it again. And, you know, you can probably expect a similar rehabilitation and outcome. And so I always feel a little more confident in a situation like this, even if it's a big operation, because I've been through it with them and they know what's in store, and I'll rely on them to make that decision.
Ok, gracias. Doctor Clavijo, ¿tenemos tiempo para el siguiente caso o pasamos?
Hola, sí. Sí, continuamos con el otro caso, Manuel.
Este siguiente caso es un paciente masculino de 31 años, empleado de oficina, jugador de fútbol, de 2 a 3 veces por semana, que tiene antecedente de una fractura del platillo tibial lateral, chasquet 1, con una lesión de cruzado anterior y una lesión de la esquina posterior externa. En el primer tiempo se le hizo una osteosíntesis del platillo tibial lateral, una reconstrucción de la esquina posterior externa. Posteriormente se le llevó a retiro material de osteosíntesis, se le hizo una menisectomía parcial medial y se le hizo una reconstrucción del ligamento cruzado anterior con un injerto de tendón de Aquiles.
¿Quién está escribiendo? ¿No me están viendo? Pregúntale.
El paciente actualmente consulta por dolor medial e inestabilidad, no ha tenido retorno reportivo y no ha tenido un antecedente de trauma. Esta es la imagen de las rodillas, de la alineación del paciente, una alineación en varo, y esta es la marcha con la lateralización de esa rodilla. Tiene un varus test positivo, un dial test negativo, una inestabilidad anterior franca, con un Lashman, cajón anterior positivo y un pivot shift positivo.
Manuel, entonces, bueno, repasemos. Es una paciente que tiene una fractura del platillo tibial.
Sí.
Luego, en la fractura hace una lesión de la esquina posterior externa y del cruzado. Y se opera, se hace una osteosíntesis y reconstrucción de cruzado. No quedó claro qué le hicieron en la
reconstrucción del cruzado, perdón, osteosíntesis, reconstrucción de la esquina y posteriormente le hacen retiro de material y reconstrucción del cruzado.
Ok, y actualmente entonces está con la osteosíntesis, reconstrucción de esquina, reconstrucción de ligamento cruzado. ¿Y cuál es el problema actual? ¿Qué pasa ahora con la paciente?
Inestabilidad y dolor.
¿Tienen las imágenes?
Sí, señor, ahí están. Las radiografías, las secuelas de fractura del platillo tibial lateral, con un aumento del slot tibial, y la alineación en varo del miembro inferior izquierdo. Estas son las resonancias que evidencian las secuelas de la fractura, las secuelas de la reconstrucción, con una falla de la reconstrucción del cruzado anterior y una nueva lesión meniscal medial. Esta es la tomografía. Y estos son los diagnósticos de inicio. Una reconstrucción fallida del ligamento cruzado anterior, con inestabilidad anterior, una rodilla vara, con una sobrecarga del compartimento medial, una reconstrucción de la esquina posterolateral fallida y una insuficiencia meniscal medial. ¿Alguno de los doctores quisiera opinar acerca de las propuestas terapéuticas para este paciente?
Antes de que empiecen a opinar nuestros expertos, quiero dar la bienvenida al doctor Bob Skenk, que también nos acompaña en este momento. Y entonces quiero como hacer un resumen de este paciente. Tenemos un paciente con una fractura de platillo tibial externo, con una deformidad en varo, con una lesión meniscal medial y con una reconstrucción del ligamento cruzado anterior fallida y la esquina posterolateral también con inestabilidad. Ahora sí, no sé, ya que se conectó Bob Skenk, Bob, ¿quisieras darnos luces en este caso?
Good morning, everyone. It's nice to It's nice to see everyone. I have some good friends on this meeting, so this is a very difficult problem. If you look at if you go back to the MRI, just show the sagittal. For the MRI, the sagittal, let's see, right in here. One more forward. This one. If you look at this sagittal, the tibia is subluxed on the femur. And when you have this problem, it can be very difficult to manage this whenever you see a patient in the clinic like this. He didn't look like he had a varus thrust. And was it 2 degrees of varus and 8 degrees of posterior slope? Is that what I saw?
Sí.
Yes.
So in that situation, by and large, you wouldn't need to do osteotomies. But this because of this sublux position, it has a very high failure rate, and the tunnels on the femur of the ACL may be non-anatomic, and so in this situation, I would probably revise the ACL and the posterolateral corner without osteotomies.
Okay, gracias.
But I would use an autograft for the ACL, and I would use a Laprade for the posterolateral corner.
Ok. Acaban las preguntas acerca del tratamiento. Revisión del cruzado anterior en 1 en 2 tiempos. Osteotomía tibial en 1 o 2 planos. Revisión de la esquina posterolateral. Revisión del cruzado anterior y osteotomía solamente. ¿Y qué tipo de manejo para la insuficiencia meniscal?
Bueno, pero ya Bob nos dijo que él haría cruzado y esquina. Y creo que ese es el enfoque que él le daría a esta paciente. Bob le haría, el otro Bob, ¿le haría algo diferente o estaría de acuerdo con eso?
Well, I'd like to just say that my friend Bob's a very good friend of mine, and to bring him into such a complicated case, sort of after we've reviewed it, I think deserves either a yellow card or a red card. I'm not sure which one. I think one of so having said that, I think that Bob, didn't get the full introduction, and this patient was complaining of medial pain, and on the x-rays had quite a bit of medial OA. And I know Bob Skank very well, and he loves to do osteotomies. Loves osteotomies. Am I saying it well, Bob? So
yes, I do a lot of osteotomies. I do deflections, valgus osteotomies, and Dr. Spalding, I really respect your opinion, but I still do lateral opening, distal femoral osteotomies for valgus knees. So I do a lot of osteotomies, yes.
So and what he really meant to say is I love doing osteotomies. Right, Bob? That's what I think if you would have seen the beginning with the amount of joint space narrowing and the patient having medial pain, I think the Bobby Skank that I know would have done an opening wedge medial tibial osteotomy here in addition to ACL revision. So, and that's what
Probably, but it was 2 degrees. I thought it was 2 degrees of Varus. So, you know.
It looked like, I agree with you.
No, it's more.
It looked like more because the weight-bearing line was almost outside of the tip.
No, but I saw the measurement of 2, but the weight-bearing axis almost went inside the knee. And that is 10 degrees of Varus, and that needs an osteotomy for sure. It said 2 degrees of Varus. I couldn't tell.
I think you came in late, so I don't think it was totally fair.
Muy bien, muy bien. Ahora, Bob Marks, tú le harías la osteotomía, pero no te preocupa que ella tiene una fractura del platillo tibial externo y ella también tiene cambios en el platillo tibial externo. ¿No les preocupa hacer una osteotomía y pasar la carga ahora al compartimiento externo?
So, you know, I said earlier, I wasn't sure if it was a yellow card or a red card. For presenting such a disaster of a case, it's definitely a red card. Having said that, you know, the lateral tibial plateau anatomy didn't look too bad, and looked on the MRI, it did not look like there was much away. It looked quite good. So I think I would feel comfortable unloading to that side in view of the amount of medial narrowing, but definitely makes it more complicated for sure. As well, one other thing, the lateral side, there was, you know, on the exam, or I think it was stated that there was lateral laxity. And there are cases where you can do an opening wedge medial tibial osteotomy, and it will tighten the lateral side to a degree. And we've published a paper, a cadaver study on that, that Iftach Hetzroni did when he was with us. So if that laxity wasn't gross, I would consider just the osteotomy medial tibial opening wedge, which can retension that lateral side.
Can I put in a comment here? The alignment issue with that lateral laxity, we need to be careful that it's not a false laxity on the standing long leg x-ray, that we've got opening on the lateral side. When she stood up there, she didn't look quite as varus as the x-ray might show at that 10-degree bit where the weight-bearing line was just 10% medial to lateral. And that's where opening wedge, I think, has that advantage on the tibia. You can check as you go along, as you open, that it doesn't overcorrect, rather than just planning a 10-degree part. But I think if we're breaking it down again, alignment has to be number one, and then understanding the stability and what happened with the ACL, getting a CT scan of the ACL tunnel position to know exactly what the state of the bone is. And this might be one for osteotomy first, bone grafting the tunnels, and then coming back as a second stage to do the meniscal transplant with an ACL as a two-part procedure, making sure we've got alignment then correct. But the joint surfaces look like they'll tolerate meniscus transplant. I can't quite see the lateral plateau fracture configuration that was treated. But if that's okay, then there's probably as a two-stage.
Can you go back to the x-rays, the weight-bearing AP? Looked like there was, so Tim, how do you feel about that x-ray on the left in terms of doing a meniscal transplant?
It's not bone on bone. So I think there's still, and if there's no meniscus in there, and we said 31, age 31, so there's a room for that. And the meniscus provides extra stability to the knee. And if you're trying to build everything and the ACL's failed already, then we have a chance to rebuild everything. If it was totally bone on bone, different story, but we've got the slope correction to do, alignment correction, redoing the ACL. This is getting bigger stuff. So probably this would be a two-stage, get these CT scan, understand the tunnel position, bone graft, correct the alignment and the slope, wear a brace for the several months because the knee needs to be stable. And you're right, but that subluxation key, as Bob mentioned on the MRI as well. We've got to reduce that, which the slope will certainly help, slope changing osteotomy at the same time. So doing all that at one stage would be a good day out. So I think 2-stage.
And the reason I brought up that X-ray on the left, which looks like, to me, fairly significant narrowing, not bone on bone as Tim said, but nevertheless some significant narrowing. And my colleagues at HSS, Russ Warren and Tom Wikowitz, in their series in meniscus transplantation have found higher rates of failure and extrusion in more severe degenerative changes when there's squaring of the condyles specifically. So I'd be concerned about that being a little advanced for transplantation.
But the trouble is you may not have much else in a 31-year-old. So we might accept that 20–30% failure rate, but you're putting in that cushion, 70% will be happy with it. But again, the expectations here, as we said in the last case, this patient's in trouble and has to, whatever phrase you use, to read them that understanding of how much trouble they're in.
Para ellos de este caso.
Gregory, empezamos con Bob Skank, que con reconstrucción de los ligamentos, pero Bob Marks le agregó osteotomía y el doctor Spalding le agregó menisco, en trasplante meniscal. ¿Tú le agregarías algo o le quitarías algo de todos estos procedimientos?
I'm still highlighting that alignment is number one here, and especially with that lateral thrust to the knee. I think nothing's going to work without really evaluating and correcting that alignment of the slope. That's what's hit me hard in the last few years, is understanding this effect of the slope there. You've highlighted this 8 degrees slope. 12 degrees is a definite big number, but 8 degrees on a failed ACL starts to become very relevant.
And I'd also like to throw in that to stage the operations with the osteotomy, because as Bob mentioned, you know, sometimes you do the osteotomies, you change the slope and the alignment, and then the instabilities become far less problematic. And so that's something to take into consideration. Although I do agree with Bob Skank that that tibial subluxation, and it's good that it was pointed out, that's something that's missed a lot of times and leads to, when you just do that simple revision ACL and then it fails again, you know, you could have predicted that by noticing that one finding. So.
Ok. Entonces, si yo...
Can I ask one more question?
Doctor Spalding. Sí, por favor. Sí.
We got confused by the writing of the 2 degree. 2 degrees on that X-ray, and I think that is 2 degrees between the femoral. You've drawn an axis down the femur. If we can go back to that X-ray, you've drawn an axis down the femur and down the tibia. We'd normally have the mechanical axis from head of femur to knee. So just to rule out any confusion there, I mean, I really prefer the weight-bearing line, and then that becomes easier to describe that we're going to call it a 5 or 10% weight-bearing line, medial to lateral, and that becomes very easy to compare. And when you're talking about it as someone else, that's good. I get confused by a 2 degree, 5 degree, because that's big varus there. I suspect that 2 degrees between the 2 lines drawn down the mid-axis of the bones.
Yeah, it looks like the mechanical axis there is probably more like 10 degrees.
Yeah. So how do you in South America really talk axis?
Sí, de acuerdo, doctor Spalding. Nosotros, yo también prefiero hablar del eje mecánico, que es por dónde pasa ese eje mecánico, esa línea que va del centro de la cadera, del centro del cuello del pie, y por dónde está pasando. Es mucho más exacto y más predecible utilizar este eje que utilizar los grados. Yo estoy de acuerdo con eso.
Edgar, una nota.
Sí, Mosco.
Es que la medición de 2 grados no es concordante con el eje de carga, ¿ok? Quiere
So is that a
decir,
red card there?
quiere decir que el paciente sí tiene un varo y de hecho tiene dolor medial, ¿cierto?
Sí.
Entonces, no son 2 grados de varo.
No, de acuerdo.
Yeah, no, I was
sí,
confused by the 2 degrees. I didn't see the severity of varus. You have to do an osteotomy. There's no question about it. I don't think I got that slide completely. And like Dr. Spalding said, so it needs an osteotomy. I thought the line was through the center of the knee. I missed that. But with that degree of varus, you have to do an osteotomy. And while you're there, not only when you do a medial opening osteotomy, you best be careful, because with a medial opening osteotomy, the geometry increases posterior slope. And so 8 degrees in this scenario is too much posterior slope, but with just a standard anterior plate and the geometry of a medial opening, you'll increase that slope to 10 degrees. So there's various ways to manage that, but when you do your medial opening, you have to attempt to decrease your slope. So you could use a trapezoidal plate that Arthrex uses. I use an AO Tomofix plate, and I lock it proximally with it anteriorly displaced, and then I rotate the plate back and it decreases posterior slope. But the key with whatever technique you use is before you make your change in your medial opening, put a pin in the proximal fragment and a pin in the distal fragment. And that way, when you do your medial opening, you can see if your slope changes. Because it's like what Dr. Spalding said, there's a lot going on that day when you're doing this. And it's sometimes hard to tell intraoperatively under fluoral if you've increased your posterior slope. So using 2 parallel pins before you start really is a useful way to maintain your view of the posterior slope, because you would like to decrease this slope to 4 degrees. And certainly, I normally don't correct over to the lateral compartment, but I would look at the degree of arthritis immediately and then make that decision. Clearly, you want to be midline or slightly lateral, depending on how much osteoarthritis they have on arthroscopy. But yeah, no, clear. I apologize. It clearly needs an osteotomy, and it needs to be one in which you keep a very close eye on your posterior slope, because you could correct their varus, but you could increase their slope to 12 degrees and they'll still fail on their ACL. I hope that ends the confusion on what to do on this case. But I would do it like Dr. Spalding said, in one stage. I don't, with this much going on, I prefer just to have the patient get a stable proximal tibial platform to walk on.
Bobby, so Bob Marks know you very well.
Yes. I apologize. I didn't see the whole presentation. It's funny.
Let me ask you.
I never say, and it's so funny, I never say just revise the ACL in the corner, but I thought it'd be fun to get a discussion going.
So I think we've arrived at 2 conclusions. One is the patient needed an osteotomy, and 2 is it's definitely a red card on that play.
Let me ask you something to everybody. Some guys do resolve this kind of problem in just one surgery. But Tim and Bob and Greg say, and probably Bobby, do first the osteotomy and then do the ACL and then the posterolateral reconstruction. I know that this patient is young. So in older people, probably 2-stage is a good solution because probably they don't need the reconstruction after the osteotomy. But in young people, what is your experience doing this in 2-stage?
I think what I'm saying here is that if we've got failed ACL and the tunnel position is not good, then bone grafting femoral tunnels and doing the osteotomy is a nice 1-stage thing. And then coming back, second stage, if you're thinking of meniscus transplant, then to do a revision ACL with the meniscal transplant is a nice combination, doable surgery, reduces the risks with doing everything at 1 stage. Now, if it's good tunnels and you could get away with the ACL in those tunnels, then it would be tempting to do just the 1-stage osteotomy plus ACL at that time, because you've got one cut in the bone, a plate, and then doing an ACL around that. So that's all doable. Then the patient's got a stable knee. They're going to adjust their sporting activity, and they may not need the meniscal transplant because they've got a well-aligned leg and taken away that lateral thrust. So that's the 1 stage for that aspect, if you can get away with an ACL, but I suspect it may not be.
De acuerdo, muchas gracias. Creo que el consenso es ese, hacer inicialmente la osteotomía, corrigiendo los dos planos, injertar los túneles y en un segundo tiempo ver la necesidad de la parte ligamentaria y el trasplante meniscal. Manuel, no sé si hiciste algo, o este paciente se hizo algo más o está para resolver. Y si ya estamos listos, continuamos con María Cristina.
Este paciente es...
Just before you go on, may I ask one more question? So,
okay.
Sí, por favor, doctor Spalding.
Bob, when you're measuring tibial slope, the more we stare at that X-ray, it's where you put the vertical line on the tibia. Now that vertical line is matching the posterior cortex. I understand maybe we should be putting the line, draw the circle in the tibia to make a line. I suspect it'll be more vertical with a higher slope than 8 degrees there for a more exacting way of looking at slope. How do you measure tibial slope?
You know, I think that's a great question, and I don't have the answer as to the best way, anterior cortex, posterior cortex, circles, drawing it up the line. So I do it multiple ways and try to get a sense if it makes a difference. But I will say that slope, if I turn sideways a little bit here, looks to me like a kind of a significant slope, a kind of a high slope, as if it would be more than 8 degrees. Because an 8-degree slope, you know, normally we call 7 to 10 as normal. And so for an 8-degree slope, I would typically ignore that at the time of revision ACL reconstruction. That slope may be a little higher. And in that case, you know, as Bob Skank said, I would adjust it with my opening wedge by putting the laminar spreader posteriorly to decrease the slope a few degrees. But that looks like more than 8 degrees, which is maybe why you're bringing it up.
Okay.
Próximo.
Bueno,
este paciente es un paciente del doctor Pinzón.
Pero, Manuel, yo creo que nos toca continuar con... o sea, ¿vas a seguir con este mismo paciente u otro paciente?
No, solamente les voy a mostrar el final de lo resultado final. Se le hizo la osteotomía, se le revisó el cruzado, se le hizo la reconstrucción de la esquina posterior externa y aparte eso se le hizo el trasplante meniscal, todo en un solo tiempo. ¿Qué opinan de eso?
Looks good. Muy bien. Excelente.
Muy bueno.
Bueno, tal vez, no sé, ¿qué opinan ustedes de haber hecho la esquina posterior-externa? O sea, fíjense que fue lo que discutimos en todo este tiempo, era hacer la osteotomía, reconstruir el cruzado, digamos que estábamos entre hacerlo en uno o dos tiempos y el trasplante meniscal. Si era necesario hacer la reconstrucción de la posterior externa, posterior lateral, o solo con la osteotomía hubiera sido suficiente para estabilizarlo. Tal vez esta es la última pregunta y pasamos al otro caso. ¿Qué opinan?
I think in many cases, an osteotomy will give you relative stability. But it seems like you guys wanted to maximize your work for that day. Question for you back is, what type of posterolateral reconstruction did you use? Did you use the big Laprade one, or did you just use a fibular-based procedure?
¿Qué reconstrucción hicieron? ¿La Prade o...?
Manuel.
Ya les muestro.
Arciero.
Okay.
Con este resultado.
Arciero.
Okay.
Sí.
It's interesting question, Greg, because you know Bob Skane and his partner did a cadaver study showing that Arciero versus Laprade in terms of control, rotatory instability, and varus is the same. But I think probably it's more popular doing Arciero because it's less difficult to do it. When you got ACL plus posterolateral corner, probably seems to be better or same to do Arciero than Laprade. But if you got a posterior cruciate ligament insufficient and do a posterior cruciate ligament reconstruction, probably it's better to control the AP displacement, do a Laprade. Are you agree with me, or do you always do Laprade no matter if you got an anterior or posterior insufficiency?
I tend to do the fibular-based RCR procedure, and only use the Laprade for severe revisions and things as such. You know, to be honest, with a lot of my multi-ligament procedures and multi-ligament experience, I've gone to trying to repair and augment the lateral side very early to avoid the bigger reconstructions. So that's my take on that.
Muchas gracias. Interesantísimo el caso. Continuemos, por favor, con la doctora María Cristina Ramos. María Cristina, por favor, continuemos. Manuel, deja de compartir la pantalla, por favor.
Muchas gracias, muy buenos días. Primero que todo, felicitarlos por las charlas tan buenas que hemos escuchado en estos 3 días. Vamos a presentarles vamos a ver si alcanzo a presentar los 2 casos. Son casos que están pendientes para resolver. ¿Ya están viendo mi pantalla?
Sí, María Cristina, perfecto. Amplíala, ponla en modo presentación. Eso, perfecto. Ya estamos.
Entonces, como les decía, son casos que están pendientes para resolver. El primero de ellos es un hombre de 17 años. En el momento en que tuvo la lesión era estudiante. Él pertenecía a un club deportivo con aspiración a pertenecer a un club profesional de fútbol. Tuvo inicialmente una lesión en el 2018. Aparentemente se tomó una resonancia, ya les voy a mostrar las imágenes, que aparentemente fue interpretada como normal y le dieron permiso para seguir jugando fútbol. Nuevamente, en julio del 2019, es decir, un año después, presenta una nueva lesión y se toma una nueva resonancia, que es la que valoramos. Esta es la primera resonancia, que es la de agosto del 2018, con la primera lesión. Estos son los cortes axiales. Aquí tenemos el corte coronal de la rodilla, donde aparentemente, sobre todo especialmente aquí, compartimento externo, pues aparentemente hay algo de líquido articular, no se ve mayor lesión del menisco externo. Vamos a la corte sagital. Tenía difíciles abiertas todavía, un cruzado posterior. Al parecer había algo aquí de ligamento cruzado anterior, o lo interpretaron como un ligamento cruzado anterior normal. Y por esa razón probablemente pues, le dieron permiso de seguir jugando. Compartimento externo no le encontraron mayores hallazgos. En ese momento, ya les voy a mostrar la resonancia del año siguiente. En ese momento, aquí están las radiografías de este paciente que son al año siguiente de donde tuvo la segunda lesión, son unas radiografías dentro de límites normales. Y esta es la resonancia un año después con la segunda lesión. Ya se observa ahí efusión articular de manera importante. Y una apariencia aquí, en este corte, a ver si logro pararlo, aquí, donde no se observa ya el contorno del menisco externo de una manera satisfactoria en el corte axial, y en el corte coronal hay una lesión del cuerno posterior, una extrusión de ese menisco externo. Vamos a ver si aquí tenemos el corte sagital. Compartimento medial, la ausencia del ligamento cruzado anterior, una contusión externa del cóndilo externo importante, y ya no se observa cuerno posterior del menisco, no hay una lesión, o hay una lesión del menisco externo que fue interpretada como una ruptura en asa de valve de ese menisco externo. El paciente se programó para una reconstrucción del ligamento cruzado anterior y una sutura meniscal de esa asa de valve del menisco externo. Se inició la artroscopia diagnóstica, el compartimento patelofemoral está sano, el compartimento medial está sano, hay una lesión completa del ligamento cruzado anterior, y cuando se evalúa el compartimento externo se encuentra esta lesión del menisco externo con hay una ausencia completa del cuerno posterior, queda un remanente de la inserción de la raíz posterior de ese menisco externo, un cartílago que está en perfectas condiciones en el compartimento externo. Entonces, lo que se hizo en ese momento fue terminar la cirugía con la reconstrucción del ligamento con unos isquiotibiales, un autoinjerto isquiotibiales, que es un injerto de 9 milímetros en una posición anatómica, con una rodilla estable, y este fragmento del menisco, del cuerno posterior del menisco externo, se le hizo una remodelación para evitar que produjera pinzamientos en el futuro. El paciente se le hicieron 2 controles posoperatorios, inició la pandemia del coronavirus, entonces no volvió a control, y nuevamente lo evalué hace aproximadamente un mes. Este es el estado clínico de este paciente. La marcha es normal, no, en este momento está asintomático de dolor, no se queja de dolor, él no ha continuado o no ha retornado, no ha intentado volver a jugar nuevamente. Actualmente tiene 10 meses de cirugía de la reconstrucción del ligamento cruzado, el arco de movilidad ya está completo y la rodilla es muy estable, tiene un lagman negativo, un cajón anterior que es negativo también, no hay pivote, el paciente no se queja de dolor en compartimento externo. Entonces, las preguntas son puntuales. ¿Qué le digo a este paciente? ¿Es posible que retorne, que vuelva a jugar fútbol con la ausencia de ese menisco externo, siendo una rodilla estable pero con un menisco externo ausente, volver a jugar fútbol? O de pronto plantear en un futuro un trasplante meniscal. Ya sabemos que la cirugía de trasplante meniscal pues no es una cirugía profiláctica, que se indica cuando el paciente tiene dolor en ese compartimento, pero pues también en qué momento podría hacerlo, en qué momento pensando en que ese ligamento pueda llegar a fallar por la ausencia de ese mismo menisco externo.
Muy interesante. ¿Quién quiere empezar?
I'll speak. I think that there is a argument that could be made for this case in a young active person who has variables that you can't really control, that being the loss of the lateral meniscus, for doing an LET or lateral extraarticular tenodesis in this case, to try and gild the lily, so to speak, and give you some added stability to that lateral side of the knee. Was that done, or was that considered at the time?
I'm sorry?
This was just an isolated ACL, right? Correct? And
Sí, los demás.
was it, what graft was used?
Sí, es una lesión de entrada ligamentaria, el ligamento cruzado anterior, el ligamento cruzado posterior está perfecto, las estructuras están bien sacas. La única lesión es el ligamento cruzado anterior, la ausencia del ligamento.
Pregunta al doctor Di Felice si usaste hamstrings o HTH. ¿Qué injerto es?
Siempre uso hamstrings. Me gustan los
Hamstrings. To use hamstrings.
It's tricky indication. I think if I could play the cards, I would have added the lateral side to that. The first go around, I may even consider adding the lateral side at this point in hindsight, because you're not going to be able to hold this patient back from playing soccer, and then they have a very high, they have a rather high risk of just tearing that ACL again. So I would give some consideration to that. Although it's admittedly it's not mainstream.
I think it's a good point. You know, this patient has several risk factors. You know, their age being by now 18 or 19 is a risk factor. He's a soccer player is another risk factor. And a somewhat theoretical risk factor is absence of lateral meniscus. As Greg said, that's been shown in biomechanical studies to put more strain on the ACL. And, you know, he's had a hamstring graft, which, you know, I think has a higher failure rate than patellar tendon. So it's a tough situation that there's no great solution unless you live in Coventry, where meniscal allografts work really well. You know, I personally don't do meniscal transplantation in a young person who's had a meniscectomy right away with no symptoms. Maybe it's the right thing to do. Tim will tell us if it is or not, but it's not something that I do. So this is tough, doing a lateral tenodesis, as Greg said, maybe a good idea. Counseling and maybe not to return to soccer is a good idea, but unlikely to be successful. So let's maybe Tim, tell us about whether a meniscus transplant's a good idea here.
So I'm understanding here, this was a slight surprise to find that complete disruption of the meniscus, not repairable, all rounded off at that end. So, and no bridge of tissue over popliteus at all. So big dilemma at the time, can't repair it, remove any mechanical catching, and then he's in trouble. And you've got a nice stable knee, you've done your best ACL, and you see how he goes. Now he's getting to that 9 months bit, and he tries sport. At the moment he feels good because the joint is coping. Quite likely that when he starts to do a bit more, he'll start to get pain. I think keeping a very close eye on him, an MRI scan at another 6 months' time, looking at the joint surface, getting one now as a baseline, another one 6 months, a year. Quite likely very soon he'll start to get symptoms and then realize that his joint is in trouble, and that's your perfect candidate for a lateral meniscal transplant. I would agree not doing it immediately, partly because you didn't know the meniscus was like that, but to do it before going back to sport, he's just getting over one operation, so let him go try sport, keep a close eye on it. Hopefully he won't run away. Again, I know you said COVID kept him away, but yeah, he's heading for meniscus transplant, and he is your perfect guy. He's got to realize he's in trouble in that knee. You keep him under review, and then do it. And they're the ones that'll be most happy once they realize they're in trouble.
Can I make a comment or actually ask a question? It's kind of a two-part thing. I think when you see those menisci round off like that, usually that gives me the impression that this patient was brought to surgery on in a chronic situation, because oftentimes when they rip immediately, they don't curl up as much. So I do think there's an argument that's kind of being birthed in the literature right now that we should be going back to more acute surgery so we can try and address that radially split meniscus and some of these other injuries before they curl up and become irreparable. The question part of this comment is, does anyone what do people think about perhaps repairing the anterior 2/3 of the meniscus, tacking it to the popliteus tendon to try and get some bit of stability to that meniscal remnant, to maybe create some stability to the knee from that meniscus? I know that in France, in Lyon, with Sonnery Cote's group, he's shown that stitching to the popliteus doesn't have a deleterious effect. And he uses that as, and I was surprised by that because I always avoided it. But what's people's thoughts on that?
I think stitching a meniscus that's intact using popliteus as a good holding ground for any sutures is fine. The sutures may self-release after a few months. They may be a bit more painful afterwards, but I don't see a problem with using the popliteus. We tend to try and miss it, but if the sutures goes through it, I don't see that as a problem. In this situation where you've got no meniscus there, it's completely gone, I haven't thought of that option of trying to fix back the anterior part of meniscus just to popliteus. That would make me think.
Just a thought. I mean, just, you know, these situations are very, very difficult, and like you just mentioned, we all kind of have a gut feeling of where this is going for this patient.
Well, actually, you know, I think this is less difficult because meniscus transplant is now a good operation. It's established that, and when the joint surfaces are good, we have a nice reproducible technique, and we can help people with symptoms. So it's become a nice, good outcome for the destroyed lateral meniscus. And the worst scenario is the patient 10 years down the line who presents then knowing they tore their meniscus a while ago, and they've now got a damaged joint, and they're 10 years older and they're 28 with a damaged knee. That's the difficult situation. Then we're into osteochondral allograft. So this is perfect. He's ripe for a meniscal transplant as soon as he realizes it.
But how do you feel, Tim? You said as soon as he realizes it. So you mean you're going to wait for him to get symptoms? Because here's the dilemma. If, you know, he hasn't had any symptoms and he's not complaining, he wants to go play soccer. And if you put a transplant in, obviously that may wreck the transplant if he's playing soccer on it. Alternatively, if you wait till he has symptoms, sometimes then there are some changes. So how do you manage that? And did I hear correctly?
Yeah, there's a good element of talking to the patient and understanding what he wants to do. There's a logic in putting a meniscus in there because it must be sensible to do because it provides protection to the joint surface. But it carries risk to it. And if you've got a flavor of the patient, you've seen them a few times, you get that idea as to how we're going to handle it. So I think the answer is that we need to do that follow-up and get an understanding in 6 months' time what he's like clinically. The cynical view is you send him for a 5-mile run and he's going to have pain. Brilliant. Now we can do your operation. Step this way. That's an easy way. Force him to have symptoms and you've made it happen. But he's got to realize. And there's some families may say, you know what, it's obvious I need a meniscus. I'm happy to take sport as a maybe if I get good result. So I want it now. And then they would understand that way.
Yo tengo una pregunta para ustedes. Es claro que el menisco, la indicación clara de un trasplante meniscal es el dolor. Si este paciente no tuviera una buena estabilidad, no tuviera un Lachman 1, 2 con un pequeño pivote, ¿ustedes pensarían en hacer un refuerzo anterolateral o hacer el trasplante meniscal? ¿O ahí sí estaría indicado hacer el trasplante meniscal de una vez? La pregunta más concreta es, ¿funciona el menisco o una indicación del menisco es la inestabilidad?
Is that for me? I think, you know, we must have this gut feel that the meniscus is very important in that knee. But surgery still carries a small risk, so it's a tough decision. And if you can explain it and see the patient on a few occasions, the answer will become clear. Now, I get referred quite a few of these patients who are likely to be in trouble. And it's interesting seeing how if you've taken a month or two to get to see them, how their knee has improved much of the time while they're waiting. It's nice now that surgeons know there is an option of meniscal transplant, and then we can counsel them for it. But not everyone needs it. That's the trouble. And we're still going to have problems with doing the surgery. Still got issues. So at the moment, it's still wait. If they've got some symptoms, then do it, not rush into it.
I'm gonna say this in Spanish to you understand me very well. In Colombia, we have a Nobel Prize, Gabriel García Márquez, quien escribió un libro que se llamó Crónica de una muerte anunciada. Y para mí este caso simplifica eso, porque cualquier cosa que le hagamos a este paciente no va a ser un buen resultado. Yo pienso un poco diferente al doctor Spalding con respecto a la indicación del trasplante meniscal en asocios de inestabilidad, a diferencia del trasplante por dolor post-meniscectomía. En este último, el trasplante profiláctico no está indicado, por la sencilla razón de que solo alivia síntomas. Pero en un paciente que ya tiene una reconstrucción, que es menor de 20 años y que ya tiene una pérdida del menisco lateral, esperar a que él haga síntomas es esperar a esa crónica de esa muerte anunciada. En mi opinión, en estos casos, yo insisto con su familia y el paciente en que él no puede volver a hacer ningún deporte de contacto.
Gregory, sácanos de este dilema.
Muted. Sorry. As I mentioned earlier, I think that this paternal aspect of medicine has really been abandoned, meaning that I feel like we should be telling people that I don't think cutting sports is a good idea for you. I had a 15-year-old girl in my office the other day who had an ACL reconstruction from another surgeon, not at my hospital. She had a patella tendon reconstruction. She was 15, played soccer. She passed all of her return to sport metrics and returned at 9 months. And on the first practice back, she tore her patella tendon graft in half. And I talked with the family and said, you know, you need a revision. I'll do your revision, but only on one condition, that you agree to not play soccer anymore. And I think that as a profession that we avoid this conversation like the plague. We think, or you know, society thinks that sports at all cost is the right answer, and we all know that these surgeries that we're doing are going to leave a lot of carnage going forward with arthritis in life. And I think that these are things that we should not be shy about talking about, or at least make it abundantly clear to our patients what the consequences of continuing in cutting sports is going to provide them, given these ugly knees.
There's one more reality here that we would end up doing is it takes a while to get hold of a meniscus transplant. So that acts as a stalling technique, and we'd send the MRI scans to the tissue bank, and it could be 6 months. In England, this is our local scenario then. In England, it could be 6 months, and especially right laterals are in short supply. So send the scans off to the tissue bank, and then it may be 6 months, it may be a year before we get hold of a graft allocated. And during that time, then review the patient. So it acts as a stalling. You've explained to the patient you're in trouble, you're heading for that operation, and then you can make a second decision later. But you're absolutely right, Greg, that idea of explaining them to the risks and how they should potentially adjust their expectations is quite real.
Bueno, pues interesantísimo el caso. Creo que cerramos con broche de oro esta discusión. María Cristina, felicitaciones, muy bien presentado el caso. Y pues esta es nuestra última sesión del día de hoy. Finalizamos el Congreso. Quiero despedir este salón dándole gracias, obviamente, a los conferencistas internacionales. Le dieron a este Congreso un nivel espectacular. Gracias también a los conferencistas nacionales y a todos que estuvieron detrás de esto, a la Junta Directiva, al Comité Ejecutivo, a la industria. Pues todos sabemos que sin la industria no hubiéramos podido hacer este Congreso, que para todos fue nuevo, un reto bien importante porque no nos había tocado enfrentarnos a una situación como la que enfrenta el mundo hoy en día. Gracias también al equipo logístico, Bemotic, espectacular, a pesar de que hubo uno que otro inconveniente, todo se resolvió rápidamente. Al equipo de traducción, muchísimas gracias, espectacular. Pudimos entendernos perfectamente. De verdad, a todos gracias, a los asistentes. Tuvimos una asistencia de promedio de 300 personas en todas las salas. Muchas gracias nuevamente. Esperemos que el año entrante Bob Marks, Bob Skeng, Dr. Gregory, nos podamos ver, Dr. Spalding, nos podamos ver en Barranquilla, pero presencialmente, y que ustedes puedan ver nuestro país y conocer nuestro país. Bueno, Bob Skeng ya está adoptado, ya tiene nacionalidad, pero esperemos poder dar la nacionalidad a todos ustedes.
Sorry, Bob is not American surgeon. He was born in Colombia, but nobody knows that he's from Colombia. Thank you so much to my friends. Thank you so much.
Muchas gracias a todos, muchas gracias por su asistencia, por su participación, y estamos seguros que esto fue un éxito. Gracias a todos los que intervinieron y colaboraron con este nuevo proyecto. Muchas gracias. Un aplauso a ustedes.
Thank you, everyone. Fantastic. Thank you.
Thank you.
Bye.
Stay safe.
Stay safe. Yes.
Bye.
Hopefully see you
Hasta
soon.
el año próximo.
Buen español.
Bien, Bob.
Bye. Gracias,
Bye.
Edgar. Felicitaciones.
Muy bien.
Pablo. Andy, gracias. Todos.
Gracias.
María Cristina, extraordinario. Todo.
Gracias a ustedes por la invitación. Un abrazo.
Extraordinario. Caso difícil, te quiero decir, el que pusiste.
Aquí.
Sin solución, lamentablemente.
Que siguen en vivo.
Bueno, muchas gracias. Bueno, adiós todos. Gracias.
Gracias.
All right. I'll say goodbye from sunny England. All right. Bye-bye.